The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello guys, welcome to your Pediatrics Pearls. Again, this is Doc Ian, one of your lecturers in Top Notch. Nice to meet you again, and I hope marami na kayong natutunan sa Pedia. I hope you guys are on your way to being ready to get high scores in pediatrics. So the Pearls is 100 question and answer type review. And because this is just a review, we will be going faster than our usual phase. Okay guys, sana marami kayong mapulot. When I was reviewing for the board exam, this Pearls is very important to me. Sobrang useful niya. I use this as a quick reference, saka parang ito yung mga last minute na bubuklatin ko because these are the items that we think have a very high chance of being asked in the board exam. And even though directly baka hindi ito yung matanong, the construction and the choices, marami kayong mapupulot, enough to equip you well, especially during the time na malapit na exam or even during the exam day itself. Alright, so let's start. Okay. 1-year-old male presented with fever, weakness, sore throat, cervical lymphadenopathies, and organomegaly. Okay? Which of the following is an expected laboratory finding in this condition? So, anong sakit yung iniisip niyo dito? Teenager to, meron siyang fever, may sore throat siya, may lymphadenopathy siya. Probably, isipin mo, worty or any head and neck infection, di ba? Sore throat, tonsillitis. However, 17-year-old, tonsillitis, common pa ba? Di ba mas common ang ating tonsillopharyngitis, lalo na kung viral pag mga bata-bata lang. Kaya lang ito, meron kang splenomegaly. Okay? So, if you know this disease, you know that it presents with sore throat, with fever, with lymphadenopathy, plus organomegaly. Okay? Tapos, 17-year-old teenager. Kung alam mo yan, actually may idea ka na. Anong sakit ba yung iniisip nila? Kasi before you can answer that, dapat alam mo yung sakit, di ba? Kasi kung iniisip mo lang strep throat, streptococcal pharyngitis, ang isipin mo, ASO titer yung sagot. No. The answer here is the presence of atypical lymphocytosis because this disease is talking about what? The question is talking about what disease? It's your infectious mononucleosis. Are you familiar with this? This is your kissing disease kasi sexually transmitted siya. Pag naghahalikan kayo, laway, di ba? 17-year-old teenager, medyo mapupusok na yung mga kabataan ngayon. Okay? So, this is caused by your Epstein-Barr virus. Okay? And presumptive diagnosis is your typical symptoms. Ang mnemonics ko dyan is F. Okay? Bakit? Bakit F? The F's of infectious mononucleosis. Ano yun? Fever, pharyngitis, okay, lymphadenopathy, and Epstein-Barr virus. Okay? Pilit na naman, Doc. Number 1 question pa lang, pilit na yung mnemonics mo. Guys, di nyo makakalimutan yan. So, infectious mononucleosis, remember the F's, the 4 F's. Fever, pharyngitis, lymphadenopathy, Epstein-Barr virus. Okay? It's confirmed by looking for your heterophil antibodies. This is your heterophil positive antibodies, your Paul Bonnell antibodies, which are specific for EBV. Do take note that there's a lot of disease that can cause mononucleosis. Okay? Pero one of the most notorious ones will be your EBV causing your IM, okay? In which, again, you have your Paul Bonnell antibodies. Okay? So, generalized adenopathy is present, organomegaly. Most feared complication is the presence of splenic rupture due to trauma. Though, that's why with these patients, you advise them to avoid contact sport. You advise them to avoid any form of contact, for that matter, during the first 1 to 2 weeks of illness because these patients might be prone to splenic rupture. Again, management is supportive, complete recovery in most patients without complications in around 2 to 4 weeks. All right. Second question. 14-month-old boy, high-grade fever for 3 days, generalized rashes as the fever lies. You're concerned about the simultaneous occurrence with this condition. Ano ba yung pwedeng mangyari sa kanya with this condition? Okay, and ang tanong is, which viral infection has the predilection of suppressing all cell lines within the bone marrow? So, ang tinatawag dito sa condition na to would be your aplastic crisis, di ba? So, with this disease, okay, pwede siyang mag-trigger ng aplastic crisis. And anong sakit yan? This is actually sabi ko sa inyo during the review, guys, ilan lang yung sakit or yung viral illness sa bata na ang pattern is maglalagnat, pag nawala yung lagnat, magkaka-rashes. Anong sakit lang iisipin doon? It's either dengue, okay? Sa dengue, pag nawala yung lagnat, lumalabas yung rashes, toxic most of the time kasi yan yung critical phase eh. Pero this one, naglagnat, nawala yung lagnat, lumabas yung rashes, usually yung bata hindi na siya toxic kasi magaling na siya. Unless magkaroon siya ng aplastic crisis, which is very rare. I've yet to see one. But for the board exam, you should know this dahil laging tinatanong yan. Aplastic crisis, it can be triggered by your roseola infantum. Okay? But do take note, guys, aplastic crisis, aplastic anemia, it's not only roseola that can trigger that. Okay? Other viruses as well. Some forms of Coxsackie viruses can trigger that. And in fact, a lot of viruses can trigger that. Okay? So, please do remember that. Hindi siya exclusive. Pero, very common sa board exam. In terms of board exam question, na it's your roseola infantum that can trigger it because it is caused by your HHV6. It can suppress your cellular lineages within the bone marrow. Okay? So, again, remember roseola. Given na yan. Automatic yan. Okay? Pag naglagnat, nawala yung lagnat, lumabas yung rashes, think of roseola. Okay, you have a 2-year-old girl presenting with colds, hyperemic conjunctiva, high-grade fever for the past 4 days. Rashes were noted on the face, tapos kumalat sa trunk. What would be an indication for admitting this patient? Anong sakit to? Colds, conjunctivitis, plus or minus cough. Okay, di ba? The 3 C's. Cough, coryza, conjunctivitis, and then you have rashes, okay? Nauna sa face, pababa, cephalocaudal distribution, maculopapular. This is your measles. Among the choices, alin ba dyan yung indications for admission? And of course, 3-year-old to, the best answer would be takip niya with retractions, okay? 35 for a 3-year-old na RR, pasok pa yan. 55, that is already takipnik. Remember the cutoff. Newborns, the RR cutoff is 60. So, 2 months up to 1 year of age, that is 50. Okay, 1 to 5, that is 40. 6 to 12, that is 30. And beyond 12, that is your adult cutoff, which is 20. So, 3 years old, sabi natin, 60, 50. So, sa 3 years old, dapat hanggang 40 lang. So, yung 35 pasok pa, yung 55 hindi na. Okay? Nagtatay siya, okay lang. Pero nakakainom naman siya ng Orezon. Okay lang yan. Okay? So, RNA virus, Paromyxoviridae, airborne infection, incubation period is 8 to 12 days. Communicability, tinatanong yan, plus or minus 4 days before and 4 days after the rashes. Most common complications of measles is otitis media, and diarrhea. Please remember that. Pneumonia is not the most common complication of measles. The most common is otitis media and diarrhea. Pag ang tanong sa inyo, most common cause of mortality and morbidity, yun yung measles pneumonia. And again, how do you prevent complications for measles? Is there a cure? Management is supportive, di ba? Pero how do you prevent complications? You give your vitamin A. So, yun yung tinatanong lagi sa exam. Okay? 12-year-old girl with low-grade fever, maculopapular rashes, which started on the trunk and post-auricular lymph nodes. What is your most likely diagnosis? Okay? So, this is called your 3-day measles. Shorter ang kanyang duration, okay? And ang clue nyo dyan is posterior auricular lymph nodes. Again, hindi naman lahat ng posterior auricular lymph nodes is rubella. So, the answer here is rubella. Rubella or German measles, okay? So, hindi lahat ng may lymph nodes sa likod ng tenga is rubella. But, in the exam, again, nagrashes, naglagnat, you're thinking of a viral exanthem, tapos may posterior auricular lymph nodes, mas maikli yung course ng fever, then probably that is rubella. So, rubiola or measles, please remember the 3 C's. Erythema infectiosum is your slap cheek appearance. Varicella, the clue there is all stages present at the same time. And again, rubella, 3 days fever, posterior auricular lymph adenopathies. Okay, so again, retroauricular or posterior cervical adenopathies. And like measles, it's also cephalocaudal. Okay? So, yan. Okay? Alright. You diagnose a 14-year-old girl to have varicella on her 3rd day of illness. Which of the following is true? Okay? No longer infectious once the fever lyses. That is not true. Varicella is still infectious as long as you have lesions. Pag hindi pa nag-erupt lahat ng lesions at may mga hindi pa nagka-crust na lesions, okay? Acyclovir is initiated within the next 4 days to shorten the course. Well, you can give acyclovir. It's best to be given within the first 3 days, pasok siya, but theoretically speaking and by the guidelines, you only give acyclovir for patients who are immunocompromised or those with complicated varicella. Otherwise, it really doesn't alter the course of the disease, okay? Varicella immunoglobulin may be given to children within 48 hours. Again, we give this for patients who are immunocompromised. So the answer here is letter C, okay? Can be given within 5 days to modify the course, okay? So if your patient has not yet been vaccinated for varicella or has not had clinical infection before, then you can. So, pag may nag-chickenpox sa bahay, pwede ka mag-prophylaxis dun sa kanyang household na unvaccinated pa or hindi pa nagka-varicella, but you have to give this within 5 days, okay? So, you can give the vaccine within 5 days to modify the course, okay? So, please remember that, okay? So, human herpes virus, it is airborne. The incubation period is 10 to 21 days with a median of 14 days. 1 to 2 days before the onset, the patient is communicable until 3 to 7 days after the onset. And ito important, all the lesions have crusted. Okay? Post-exposure prophylaxis, you can give the vaccine within 5 days of exposure. Maximum yan. Ideally, hanggang 72 hours, pero pwede pa hanggang 5 days. Okay? Immunoglobulin, we give it within 96 hours for those who are immunocompromised. Immunocompromised, buntis, and pregnant. Okay? Which virus has the predilection to affect the erythroid cells and lead to a transient aplastic crisis? So, much like yung inyong roseola kanina, this one can also trigger an aplastic crisis and it affects your erythroid cell line. This is your parvovirus B19, your erythema infectiosum presenting with slap cheek appearance. Okay? So, it targets your erythroid cell line, causing lysis, depletion, and arrest of your erythropoiesis. Okay, remember for this one, it also spares the palms and the sole. Another thing to remember about erythema infectiosum. Okay, mother with no prenatal care gives birth to an infant who is small. IUGR, microcephalic, hepatosplenomegaly, intracerebral calcifications, no history of raw meat exposure. So, importante yan. Pag may raw meat, baka ibang sakit yung isipin mo. But even if you don't know this sentence, pag nakita mo na itong mga to, so IUGR, microcephaly, think of congenital infection. Top of the list will be torch. Ang tanong is, alin dun sa mga torch na yan? So, ang tanong dyan, alin dun sa mga torch na yan? Kasi usually pare-parehas yung manifestation nila, IUGR, microcephaly, hepatosplenomegaly. But then you have here a finding of intracerebral calcification, which means you can narrow down your choices. Ano ba yung mga common na nagkakaroon ng calcification sa mga to? It's usually toxoplasmosis or cytomegalovirus. Okay, toxoplasmosis usually pag may raw meat exposure yan. So probably hindi na toxoplasmosis. So baka doc, ang answer na natin is cytomegalovirus. Well, yes, cytomegalovirus nga ito. Lalo na pag sinabi sa inyo specifically na yung kanyang calcifications ay periventricular. Okay, so cytomegalovirus mas common sa kanyang periventricular. So again, a little rundown is herpes viridae family, most common congenital infection in your newborns, and the disease is what you call your cytomegalic inclusion disease. So ito yung sinasabi ko sa inyo. So what do you see on findings on imaging? Toxoplasmosis presents with diffuse intracranial calcifications, pero pag periventricular siya sa paligid ng mga ventricles, that is more characteristic of your cytomegalovirus. Alright? 9-year-old presented with 3 days headache, flush skin, abdominal pain, dengue ang iniisip mo. Aside from CBC, what can you do? On the 3rd day of illness, no-brainer, the answer is NS1. You have to know the timing of your diagnostic test. So, 1 to 3 days, it's NS1. So, first day of fever hanggang 3rd day, NS1. 5 days pataas, IgM would be the better test. So, theoretically, there's a gray zone, which is your 4th day. So, ako, in my practice, what I do, if I get a patient on the 4th day of fever, then I postpone the test, kinabukasan na on the 5th day, and I do my IgM. So remember, dengue has a febrile phase, a critical phase, and a recovery phase. Okay? Critical phase is your defervescence. Pag bumaba yung fever, nawala yung lagnat, the first 24 to 48 hours is your critical phase. It is characterized by plasma leakage. Magli-leak yung plasma, which will cause an increase in hematocrit kasi lumalapot yung dugo, and a decrease in your platelet. Okay? And that's the hallmark of dengue. Pag naitawid mo siya ng critical phase, recovery na yan, gagaling na yan. Management is supportive, and fluid therapy. Okay? Ito na naman tayo with the F and F confusion. Alright? So, right, number 9. 5-year-old boy presents with paroxysmal cough. Okay, paroxysmal cough, 7 days, walang fever, walang dyspnea. Very high WBC, more than 20 with lymphocytic predominant. What is your most common etiology for this disease and this condition? So, giveaway yan. Paroxysmal cough, lymphocytosis, high WBC more than 20. Kulang na lang dyan sabihin niya yung cough niya, it's described as burst of coughs, parang machine gun, sobrang tuloy-tuloy. Namumula yung muka, halos lalabas na, luluwa na yung mata niya. Okay, yan yung description, textbook yan. And then at the end of that bout of cough, para siyang mawawalan ng hininga, ending with an expiratory woof. Magkakaroon siya ng ganun, nagkakaroon siya ng whoop. So that is your whooping cough, that is your pertussis. Etiologic agent is your Bordetella pertussis. Okay? So, etiologic agents, sa mga choices natin, Corynebacterium is diphtheria, Mycoplasma pneumonia is your atypical pneumonia, Hib causes your epiglottitis, okay? And more pesto, nagugutom pa yan ako. Wait lang, guys. And, of course, pertussis, Bordetella pertussis, it's very high WBC count. That is what you call your leukemoid reaction with absolute lymphocytosis, okay? Yes, bibigyan kita ng pesto. How do you prevent pertussis? Of course, vaccination, and it's part of your EPI. It's part of your Penta, your 5-in-1 vaccine. Di ba yan yung DPT, diphtheria, pertussis, and tetanus. Alright? Gagawin ko muna si Ino ng pesto pasta. 2-year-old girl presented with 2-day high-grade fever, lethargy, ecchymosis all over the body. My God, giveaway. Right? Bacterial infection and concerned about exposure. Which of the drugs should you give to those who are exposed? Okay? Tapos ito yung itsura niyan. Okay? Clue. Dok, pwede bang Hinoxunline purpura yan? Well, Hinoxunline purpura, medyo ganyan yung itsura niya, pero usually hindi siya nagkakaroon ng ecchymosis. Usually petechiae lang siya, saka purpura. And another clue here is, ito, 2 days lang yung course, sobrang bilis. Mabilis yung course, tapos lethargic na yung bata, toxic na siya. This is a case of meningococcemia, okay? So your Neisseria meningitidis infection, the prophylaxis of choice is ciprofloxacin, okay? So meningococcemia, abrupt onset, rapid worsening, morbilliform rash, becoming petechial, becoming purpuric within hours. Prophylaxis for children, it's rifampicin, please remember that. Okay, you can also give ceftriaxone. Okay, but for patients 18 pataas, ciprofloxacin is the drug of choice. Alright, so please remember these kasi laging tinatanong sa exam yan. Which of the following is correct regarding the diagnosis for enteric fever or typhoid fever? The mainstay is serologic test, of course not. The mainstay is your culture. Okay, urine culture become positive during the first week of illness. So sabi nga natin ang pneumonia is BUS, di ba? Blood, urine, stool, 1 week, 2 weeks, 3 weeks, okay? And at any time, ang pinaka-high ang yield would be your bone marrow aspirate, pero of course, that is invasive, di ba? Papipiliin ka, iihi ka o tutusukin ko yung bone marrow mo. Siyempre, iihi ka muna, okay? So, urine culture, usually 2nd week onwards yan. Stool culture becomes present on the 2nd week of illness, and patients with mild illness may have thrombocytopenia and DIC. Of course, thrombocytopenia and DIC, syempre hindi na mild yan. So, the correct answer is letter C. Doc, akala ko ba stool is 3 weeks onwards? Okay, actually, if you read the book, guys, ang sinasabi lang dyan is for the first week, it's your blood, okay? Actually, 2nd week onwards, urine or stool na yan, okay? So, ito yung finer print sa book. So, kaya within these choices, this is the best answer. Okay? So, yung BUS mnemonics, ano yan? Med school mnemonics yan, board exam mnemonics yan, but it's still useful. So, again, it doesn't mean na pag first week, it doesn't mean na kapag 2nd week, urine lang, or 3rd week is stool lang, no? Okay? What's simply telling you is the first week, pinaka-okay ang blood. Okay? 2nd week, pinaka-okay ang urine. Pero pwede ka na rin mag-test ng stool. Tapos 3rd week, pinakamataas yung yield mo pag stool yung kukunin mo. Okay? I hope that's clear. Doc, kailan po tayo nag-BMA? Again, highest yield ang BMA. You can do it at any point of the disease. Okay? So, only problem, again, it's invasive. Doc, always may makukuha ka ba? In my, ilang years na ba ako nagpa-practice as pediatrician? In my 6-7 years of practice as a pediatrician, siguro mabibilang pa lang sa daliri yung talagang nakakapag-culture, nakakapag-isolate kami ng typhoid. Medyo mailap si typhoid, si salmonella. Okay? So, WHO guidelines confirmed case is fever for 3 or more days, but in practice, and again, clinical clue for the exam, usually, I consider typhoid pag sobrang haba ng fever, pag lumalampas ng 7 days, okay? With confirmed S-typhi, blood, BM, or bowel fluid. So, that is what you call your confirmed case, okay? So, pag may fever ka, meron kang serodiagnostic or antigen detection, pero wala kang isolation, that is only a probable case. And in this table, you will see the signs and symptoms of typhoid in children. Hindi common yung relative bradycardia na nakikita sa adult. Hindi rin common yung laboratory finding na mababa yung WBC. You can see it, but not that common. So fever is still the most common. Surprisingly, coated tongue daw, 76%. And of course, you have non-specific signs and symptoms, diarrhea, anorexia, hepatosplenomegaly. Typhoid is one of the great mimickers, okay? So other useful clues, fever rises in small increments and it is remittent, may reach 40 by the end of first week, usually sa hapon, okay? Constipation can be a presentation and diarrhea. And yan, sinabi ko na kanina, bradycardia is not that common finding, okay? And duration of the fever is only significant predictors, the only significant predictor, okay? So what about the IgM, IgG typhidot? So as you look, okay, again, the figures may vary. Some figures will say that it is very high specificity and sensitivity. But this is from Nelson, so if you look at the data, okay, not that high actually. And this is what we also see in clinical practice. So, ang dami naming maiilap na typhoid dot negative, wala kang ibang focus, then you treat for typhoid and the patient resolves and responds well. Okay? So, yan. Other signs and symptoms, and so yan, sabi dito, persistence of fever more than 7 days, bowel change, neurologic manifestation. So again, in my practice, I consider typhoid pag lumalampas na ng 7 days yung fever. And I think you should use that approach too for the board exam. Ilan lang yung sakit na more than 7 days yung fever. Typhoid, Kawasaki, ano ba? Tuberculosis. Okay? So yan. So challenges in the diagnosis, culture will yield only 40 to 60%. That is true. We see that in practice. Stool and urine becomes positive after the first week. Again, on the first week, ang pinakamaganda is blood, stool and urine beyond the first week. And other tests are non-specific. Okay? 6-year-old boy presents whose parents does not believe in immunization. Kawawang bata, anti-vaxxers yung parents. May sore throat siya, whitish gray, adherent pseudo-membrane, that's a dead giveaway. Elevated WBC with neutrophilic predominance. What is your most likely diagnosis? Whitish gray, adherent pseudomembrane in the pharynx, automatic pag nakakita ka niyan, diphtheria. I have seen 3 cases during residency, all during intubation. Imagine my exposure. Ang malas ko, ako palagi mag-intubate pagkakita ko, okay guys, diphtheria to, okay? And after that, of course, I have to do my prophylaxis, wherein I have to take either erythromycin, which is very ouchy to the tummy, or I could get a PenG shot, IM, which is also very ouchy to my puwet. Okay? Dok, anong inavail nyo po? I've tried erythromycin, I think, once during those 3 exposures, and the other 2 I opted for the PenG. So, tiis na lang yung sakit ng puwet kaysa yung sakit ng tiyan na susuka-suka ka. Again, depende sa tao yung tolerance niyan. Okay? Infectious mononucleosis, sinabi ko na sa inyo yan, mononucleosis is your Fs, your fever, pharyngitis, adenopathy, and Epstein-Barr virus. Streptococcal pharyngitis does not present with membranes. Instead, what you look for is your beefy red tonsils with exudates. And peritonsillar abscess is very obvious because you have an abscess. What happens, may bukol ka doon, may nana yun, and usually yung uvula nadidisplace siya to the opposite side. Okay? How is it different from strep throat? Relative lack of fever, it's non-exudative. Okay? So, very different yung itsura. Strep throat, hindi mo mimiss yan. Beefy red tonsils with exudates yan. Okay? 10-day-old boy delivered at home by a traditional birth attendant, restless, irritable, hindi kumakain, hindi mabukas yung bunganga. Spasms of both hands were also noted. Most likely, this is, okay, so, restless, irritable, hindi mabukas, and spasm. Okay, kulang na lang dinagdag dyan yung board-like rigidity. Tumitigas siyang ganun, sobrang tigas. Okay? So, sepsis, pwede. Meningitis, pwede actually. But the better answer would be your tetanus neonatorum. Okay? So, this is your tetanus. It manifests within 3 to 12 days. Usually, pag sa bahay pinanganak, walang nabigay na bakuna kay mother, hindi sterile yung mga ginamit na pangkat ng cord, so forth and so on. Okay? And very difficult to manage. Neurodisciplinary approach yan. You give your antibiotics, you give your anti-tetanus toxins, and then you have to sometimes put the patient under midazolam drip, muscle relaxants, so forth and so on. Alright? 13-year-old girl is admitted due to fever, diarrhea with dehydration, and abdominal pain. Stools are mucoid and bloody. Pagkatapos niyan, a few hours prior, nagkaroon siya ng lethargy, confusion, and seizures. What is the most probable etiology? Okay? So, diarrhea, abdominal pain, bloody stool. Sabi ko sa inyo, kapag bloody stool, ang first differential would be Shigella. Although, if you look at it, all of these differentials would cause bloody stool. It's part of our sexy mnemonics na tinuro ko sa inyo. S-E-E-C-C-S-Y, di ba? Sexy mnemonics, okay? Again, your first differential is Shigella. Ang tanong dyan is, can Shigella presents with lethargy, confusion, and seizures? Di ba, Doc? Parang mas pasok ito sa salmonella. Pwedeng magkaroon ng salmonella dyan. Well, actually, in fact, you can have toxic cases of Shigella, which can have complications such as meningitis, sepsis, and so, the best answer here pa rin, by virtue of your course, na magkaroon ka ng bloody diarrhea, dehydration, and abdominal pain. Lalo na pag sinabi dyan, tenesmus, masakit pag tumatae. The best answer would still be Shigella for this one. So, it invades the epithelial cells, dehydration, tenesmus, yan, neurologic manifestation, 40% of the time. So, not just salmonella can cause meningitis and meningismus, also Shigella. And between the two, ano yung mas common na nagkakos ng bloody diarrhea, again, is Shigella by virtue of incidence, prevalence, okay? 15-year-old boy, 7 episodes of watery, fishy odor stool for the past 24 hours. 2 cups per bout. One bout is around 200 to 250 ml. 1 cup. So, sa isang bout, nakaka 400 to 500 ml siya. Tapos, nagsusuka na rin siya. Lethargic, tachycardic, sunken eyes, prolonged capillary refill, palpatory 60. Shocked na siya sa sobrang dami ng tinain niya. Okay? Most likely, what causes this? So, alin ba yung magkukos ng copious watery stool enough to cause sudden and severe dehydration and shock with fishy odor? Kulang na lang sabihin sa inyo, yung description is rice watery stool. This is your Vibrio cholera. Okay? I've seen several cases of cholera, and yung kwento nila before sa PGH daw, merong cholera ward, ang bed may butas, sa ilalim may planggana, ganun daw kalala, hindi na halos makatayo yung mga pasyente to go to the bathroom, nakahiga na lang sila tumatae. True enough, my only experience with cholera ganun. Grabe yung diarrhea. Magsashock yung patient, bolus kami ng fluids, tataas yung BP, tatae siya, babagsak ulit yung BP, pagkatae niya, bolus ulit ng fluid. Ganun kami the whole night. So, yeah, cholera, profuse, watery, rice watery stool. Gram-negative aerobic bacillus, okay, contamination of your food or water, okay, rice watery with fishy odor, usually walang abdominal pain, okay. Drug of choice, doxycycline or tetracycline, okay. Alternative, azithromycin. Cotrimoxazole, if I'm not mistaken. Please check on that, okay. Which of the following tests is used to measure antibodies specific to Treponema pallidum? Treponema pallidum is your causative agent for your syphilis. Okay, so you have all of these are tests for syphilis, but if you're asking about antibodies specific to Treponema pallidum, it is your hemagglutination assay. Okay? Okay, so your Treponema pallidum can be demonstrated by dark field microscopy or direct immunofluorescence on skin lesions, placental or umbilical samples. Do take note, you have 2 tests. You have your non-treponemal test and your treponemal test. VDR and RPR, you are familiar with that. We use that for screening. They are actually non-treponemal tests. They detect antibodies directed against your lipoidal antigens. Okay? So, hindi sila treponemal test. It doesn't mean na meron ka talagang active treponemal infection. Your treponemal tests are the following: TPI, FTA, and dami yan. Okay? They measure antibodies specific for Treponema pallidum, and the most commonly used would be your microhemagglutination assay for Treponema pallidum, your MHA-TP. Okay? So, how do we interpret these tests? We use them together. So, this table is very important. This is very useful, especially for the board exam, not just in PEDIA. If both of your treponemal and non-treponemal tests are non-reactive, then you don't have syphilis or pwedeng very early before the seroconversion. Okay? If your treponemal test is reactive but your non-treponemal test is non-reactive, it can mean prior treated syphilis, untreated syphilis, or it can be a false positive treponemal test. Okay? If both are reactive with or without, okay, measurable titer, then it's active syphilis. Okay? Recently treated syphilis with a non-treponemal titers that have not yet become non-reactive. Okay? Or treated syphilis with persistent titers. You can have that also. If your treponemal test is non-reactive and your non-treponemal test is reactive, then it is a false positive non-treponemal test. Okay? So, take note of this. Okay? So, these are the features that you see in syphilis. Lalo na sa mga congenital syphilis, nagkakaroon sila ng mga desquamation, na katulad niyan. Tapos, mga abnormalities of the fingers and the extremities. Okay? 12-day or 2-day-old baby was born preterm, so 32 weeks, okay? Nagkaroon siya ng large volume amniotic fluid, so that's already a clue. Polyhydramnios, okay? Vomiting na bilus and jaundice. So these are all clues that when you put together, you will already know the diagnosis, okay? That you know that the patient has obstruction. Most likely, what diagnostic finding will you see when you do an x-ray? Ano bang sakit ang iniisip nyo? Preterm, jaundice, polyhydramnios, non-bilus vomiting, okay? Sinabi, bilus vomiting without abdominal distension. Sinabi ba dito abdominal distension? Wala siyang sinabi, okay? So, if you put all of that together, so again, premature, okay, polyhydramnios, kasi nga, pag lunok ng fluid, hindi pumapasok, okay, may obstruction kasi dyan, so polyhydramnios siya. Tapos, bilus vomiting, dahil may obstruction ka, okay? Pero hindi lumalaki yung tiyan. So, this is your duodenal atresia. And what do you look for in duodenal atresia? That's your double bubble sign. Okay, so here are your choices. Barium, strix of barium and constricted channel. Hindi yan. Okay, gas-filled stomach and proximal duodenum. Okay, yan ba yan? Okay, yan ba yan? Okay. Distal duodenum and proximal jejunum twist on the mesentery, that's volvulus. Transition between dilated proximal colon and obstructed distal colon, that's Hirschsprung. Okay, so the answer here is letter B. So, it's your gas-filled stomach and proximal duodenum. So, yan. So, double bubble sign. So, meron ka ng bubble ng stomach sa duodenum. Wala siyang connection, kaya pareha silang may bubble. That is duodenal atresia. Okay? Barium and constricted channel, this is pyloric stenosis. Okay? Distal duodenum and proximal jejunum twists, this is your volvulus. Okay? Omega sign, coffee bean sign, inverted U sign. Transitional zone, okay, that is your Hirschsprung's disease. Pero, dito ba siya? Hindi. Proximal colon and obstructed distal. Hirschsprung's disease. This one, I don't think this is the transitional zone. Baka hindi to. Baka ibang image yan. Okay? So, yan. So, the answer here is letter B. That is your double bubble sign. Okay? So, yan. Volvulus or malrotation is the same. Patients with malrotation, they're prone to developing volvulus. Okay? So, it's not the same. Okay? But malrotation is simply malrotation. So, hindi nag-rotate dun sa axis during the development. So, misplaced yung inyong mga internal organs. Pero, if you have malrotation, hindi naka-rotate ng maayos yung mga bituka sa loob, then it is prone to developing twisting, obstruction of the supply, of the blood supply, and then you have volvulus. Okay? So, pag nagkaroon na ng twisting sa mesentery, I think this one, the better answer for this one is volvulus rather than malrotation itself. Okay? Sabi na natin lahat to. Alright, number 18. 5-year-old boy presented with 2 days loose stool, watery base, but non-bloody. Okay? 4 episodes of vomiting as well. Nag-stop siya pag nag-NPO yung pasyente. Okay? Most likely mechanism of diarrhea. So, traditional, typical textbook description yan. Pag tinigil mo yung pagkain, pag nag-NPO ka, mag-stop siya, then probably that is osmotic diarrhea. Kasi pag secretory yan, tutuloy-tuloy pa rin yan. Kahit hindi ka kumain, tutuloy-tuloy pa rin yan. And in the board exam, you have to know this table, the difference between osmotic and secretory. In Nelson's, ang haba, ang daming criteria niyan, but here, we're able to narrow it down. Ito yung mga pinaka-common na tinatanong. Volume of stool, ang osmotic usually hindi ganun kataas. Ang secretory, mataas yan. Secretory, think of cholera. Osmotic, ano ba yung ating iisipin pag osmotic diarrhea? Think of lactose intolerance. Okay? Response to fasting, titigil ang osmotic, ang secretory tuloy-tuloy. The sodium of the stool in osmotic diarrhea, mababa lang yan. 70 mex per liter. In secretory diarrhea, that's more than 70 mex. Why? Why is it high? Remember the pathophysiology of cholera. In cholera, guys, nagtatapon ng sodium. Okay? Tinatamaan yung mga sodium pumps sa tiyan, nagtatapon siya ng sodium. Kaya nga, di ba, where sodium goes, water follows. Kaya siya secretory diarrhea. And that's why, when you check the stool, mataas yung kanyang sodium. Okay? Reducing substances, ito yung mga substance na hindi ma-digest. So in lactose intolerance, hindi niya na ma-digest, hindi niya ma-absorb yung substance na yon. So nagkakaroon ka ng reducing substances when you check the stool. Okay? And the stool pH in osmotic diarrhea is usually less than 5. It's more acidic, while in secretory diarrhea it's usually more than 6. So please remember this table, very important. Okay? 18-year-old female is found with contents of a bottle drain cleaner in her mouth. Okay? 18-year-old na to. So, malamang non-accidental to. Okay? Management. Okay? You don't induce emesis. That is a no-no. So, definitely no-no yan. Okay? Kasi, if you induce emesis, yung substance na nasa tiyan na, pwede siyang magpabalik-balik, taas-baba, mas marami siyang masisira. Okay? Activated charcoal, not all ingestions is indicated to be given activated charcoal. So, hindi lahat ng ingestion nyo, ng caustic ingestion, kailangan nyo i-activated charcoal. Ang tinuturo ko sa mga juniors ko, if you're not sure, then do not give activated charcoal. Okay? Mag-search ka muna, basahin mo muna kaysa yung i-activated charcoal mo agad. No. Okay? Neutralization is also not recommended. Actually, the best answer that you have to do if you're moonlighting and if it's in the choices is actually, you can give milk. Okay? Milk or water. Okay? Painumin mo yung pasyente. Okay? And here, the best answer here is to do your endoscopic examination. Okay, you have to do your endoscopy within 24 hours to check for the extent of damage para makita kung may mga kailangan bang gawin. And again, avoid yung complication na iniiwasan natin, which is the development of stricture, or kung may perforation siya, ma-repair yun. Okay, so yun yung pinakamagandang sagot among the choices. Okay? 20-year-old newborn via NSD to a G1P1 28-year-old mother noted to have frothing of secretions at the mouth. Okay, nung pinakain siya, nag-regurgitate siya, tachycardic, tachypnic, good cardiac tone, cyanotic lips, and nail bed. Okay, what is the common anatomical presentation of this condition? Noted in the early neonatal period. So, ano yan? Textbook. Sinabi ko na dati sa review ko yan, di ba? So, pag nag-feed, mas nag-regurgitate, nag-froth, that is esophageal atresia. The most common type is letter A. Okay? Ends in a blind pouch yung upper esophagus with a distal fistula. Okay? So, again, remember, it's one of the most common congenital anatomic anomaly of the esophagus. That is your TEF, esophageal atresia with TEF. Okay? 50% will have associated midline anomalies, vertebral, anorectal, tracheoesophageal, cardiac, renal, radial, limb syndrome. That is what you call your Vactor or your Vacteral. Okay? Remember that these are the types. Type C is the most common, wherein you have a blind pouch and a distal fistula. Okay? So these are the different types of your esophageal atresia. So remember again, A, B, C, D, E. Okay? So without fistula, proximal, distal fistula. This is your dual fistula and your H-type fistula, yung letter E. Okay? So, 3-year-old boy presents with chronic constipation since he was an infant. Globular rectal exam revealed normal tone and no feces on the examining finger. What is the gold standard for this disease? So, sinabi na rin natin yan, di ba? Constipated pero walang dumi sa puwet. Okay? Tapos, 3-year-old na siyang may chronic on and off constipation. Ano isipin mo? Hindi umaabot sa rectal vault yung dumi niya. Probably that is Hirschsprung's. The diagnostic test of choice, the gold standard is your rectal biopsy. Okay, so a ganglionosis, absence of your ganglion cells causing decreased mortality, decreased motility, lack of propagation and peristalsis, as well as abnormal or absent relaxation. The gold standard is biopsy. The management is of course your pull-through, your end-to-end anastomosis. So pull-through procedure ang tawag doon. Intermittent abdominal pain for the past 3 days, okay? Tapos nagdo-double up yung child during the episode. So on and off abdominal pain, tapos mimilipit siya sa sakit, pero in between parang okay siya. Okay? So he looked comfortable and was even playful in between. Tapos after a few minutes, nagkaroon siya ng jelly-like consistency of the stool and very irritable. What is your diagnosis? So dead giveaway yan. Namimilipit sa sakit, paroxysmal, pero in between okay siya. Okay, may diarrhea, nagtatae. Tapos ngayon, biglang naging jelly-like. Kulang na lang sinabi na medyo mucoid and bloody jelly-like. So, currant jelly, you see that in intussusception. Okay? So, volvulus is the twisting. Sinabi na natin kanina, common in patients with malrotation. Meckel's diverticulum presents with painless rectal bleeding, and please do remember again the Meckel's rule of 2, okay? And malrotation is the incomplete rotation of your intestine during fetal development, okay? Leading to the failure of the cecum to move into the right lower quadrant, okay? This is your intussusception. The most common part that happens is your ileocholic or your ileocholic, okay? So, this is what you call your intussusceptum and your intussuscipiens. Okay? Intussuscipiens, yung recipient, doon pumapasok yung intussusceptum. So, ito yung bituka, pinapakain niyang ganun. Ang nangyayari, naiipit, nawawalan ng blood supply, nagkakaroon ng edema and bleeding, and that is why you have your currant jelly stool. Okay, 60%, not all, but 60% will have the passage of what you call your currant jelly stool, the one you see here in the image. Okay? 17-year-old male presents with 2 months on and off dysphagia for solid and occasionally liquid. So, usually progressive to. Pero tignan nyo yung kwento, matatanda na itong mga to. So, usually 5 years old, 10 years old, okay? Tapos, ang problema is progressive dysphagia. Okay? Nag-fluoroscopy ka, what is your expected finding? So, isa-isayin natin. Ano ba yan? Double bubble sign, that is duodenal atresia, automatic out, newborn yan. Coiled spring sign, you see that in intussusception. Hindi rin ganyan ang kwento na intussusception. You're left with your double track and bird's beak. Double track you see in pyloric stenosis, presenting with non-bilous vomiting and an olive-shaped mass. Bird's beak sign, pag nasa taas yan, nasa esophagus, that is esophageal, that is achalasia, okay? And usually achalasia presents with such, okay? Achalasia presents with on and off dysphagia, okay? So, the answer here is your bird's beak sign. Okay, so yan, nasasabi ko na pala. Dito pala yung sinabi ko. So, double bubble sign, okay, that is your duodenal atresia. Double track sign is pyloric stenosis. Bird's beak sign is achalasia and intussusception. Alright? So, barium swallow in achalasia, it's the loss of your LES, relaxation. So, that's the pathophysiology. Okay? So, nawawala yung lower esophageal sphincter relaxation mo. Lagi siyang constricted, kaya nagkakaroon ka ng dysphagia. So, it is a functional obstruction. Okay? So, distal esophagus has narrow segment leading to a closed lower esophageal sphincter, resembling what you call your bird's beak sign. So, ito yan. Okay? Pag nakita nyo yan sa bandang puwet, Hirschsprungs yan. Okay? 24-year-old, 3-year-old, 24-year-old, number 24, 3-year-old male presented with 2 days history of high-grade fever, drooling, and muffled voice. Okay? Incomplete immunization. Pag sinabi yan, ibig sabihin yung diagnostic, differential diagnosis nyo, dapat nandun na kayo sa mga sakit na vaccine preventable, okay? Tapos, tripod positioning siya and dyspnea. What is the most likely etiologic organism? So, ano to? 3-year-old, ang bilis. 2 days pa lang, tapos ngayon, dyspneic na siya, mukhang may obstruction na, drooling, naglalaway, muffled voice, tripod positioning. Then, probably what will you think of? Virus, probably out of the question. Klebsiella, pwede sa mga respiratory infections. Pero ito, anong sakit ba yan? This is your epiglottitis. The etiologic organism for epiglottitis is Hib, or your H. influenza type B. Doc, paano mo nasabing epiglottitis to? Again, fever, high grade, okay? Drooling, sign of obstruction, upper respiratory tract, and very fast progression, 2 days pa lang. Okay? The usual viral infections, okay? Usually, hindi ganun kabilis pumangit yan. Staphylococcus, yung mga bacterial infection na iba, hindi rin ganun kabilis pumangit. If you have cases na ang bilis pumangit, febrile yan, tapos upper respiratory tract obstruction, mukhang infectious, think of Hib, think of epiglottitis, okay? And yes, okay, epiglottitis can also be caused by your staphylococcus, okay, and other bacteria, pero Hib ang pinaka-common. Okay? Remember that you do treatment under double setup, intubation plus or minus tracheostomy pag kaya, kasi most of the time nasa taas yung obstruction yan, supraglottic obstruction. Okay? So you have your thumbs up, okay? Sign, tama, your thumbs up sign. And the treatment for your epiglottitis, your Hib infection is IV antibiotics, usually 3rd generation cephalosporins. Okay? 25, 4-year-old girl presents with fever, rhinorrhea, barking cough. Ito, 3 days. Tapos, course, nagmamalat. Okay, adventitious musical breath sounds. What will you expect on neck x-ray? So, yung kanina, unvaccinated, toxic looking, mas mabilis yung progression. Ito, medyo mas matagal yung progression niya, hindi siya ganun ka-toxic looking, hoarseness, barking cough, medyo mas mukhang viral yung picture. Kanina, epiglottitis, this one, probably more of viral croup or your laryngotracheobronchitis. Okay, and on x-ray, you have your subglottic narrowing or your steeple sign. So this is your laryngotracheobronchitis and that is your subglottic narrowing. Nasa baba siya. As compared to epiglottitis, thumb up, 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 supraglottic ang inyong narrowing. Okay? Right, 15-month-old male presents with 3 days cough, colds, and fever. On PSR is 55, subcostal retractions, wheezes all over, prolonged expiratory phase. What is the most likely etiologic organism for this patient's condition? Can this be asthma? 15-month-old nagwiwheeze. Actually, pwede, di ba? May retractions, nagwiwheezing, prolonged expiratory phase. However, the patient has fever and yung tanong, etiologic organism. So, hindi asthma yan. Nagtatanong ng etiologic organism. Right? Remember the age group, guys. Again, 3 years old, pababa, usually viral yan. Newborn period, usually yan yung BEL, di ba? Group B strep, E. coli, listeria. 5 years old, pataas, pumapasok na yung mga bacterial causes, lalo na yung mga atypicals nyo. So, very important yung age group natin. So, 15-month-old yan, very young. A lot of times, these are viruses causing hyperactive airways, kaya ka may wheezing. And when we talk about lower respiratory tract infection, okay, lower respiratory tract infection in children, ang number one pa rin, overall, number one pa rin is your viruses. And ang pinaka-notorious and pinaka-common would be your RSV, your respiratory syncytial virus. Pag tinanong kayo, across all age group, ano yung pinaka-common na bacterial cause ng pneumonia, lower respiratory tract infection in children? The answer is strep pneumo. Okay, strep pneumo. Pero pag overall cause, mas marami pa rin ang viruses. Overall, it's your RSV, respiratory syncytial virus. So please remember that. Okay, so this is bronchiolitis, inflammation of the small airways, usually less than 2 years of age, most commonly caused by RSV. Viral illnesses will have your symptoms of rhinorrhea, cough, coryza, okay? And then you have wheezing and of course, prolonged expiratory phase. Okay, when do you admit? Hindi lahat ng bronchiolitis kailangan i-admit. If the patient is toxic looking, cannot feed, lethargic, in respiratory distress, of course, if apneic, hypoxemic, and even if the patient is not that bad, pero yung parents hindi siya maalagaan, then of course you have to admit these patients. Management is of course supportive, plus or minus steroids, okay? Pero hindi lahat binibigyan ng steroids. Hindi rin lahat kailangan nakasalbutamol nebulization. So we manage it supportively, alright? Based on the latest GINA guidelines, which of the following is preferred treatment option for adolescents? Okay, so there are different treatment options for children, for patients less than 5 years old, lalo ng iba na naman yan, and then for adults and adolescents. Ang tinatanong dito, adolescents with mild asthma, okay, what is the preferred treatment option? Mild asthma taken as needed for symptom relief. The answer, if you were to discuss this 10 years ago, the answer would be SABA, di ba? For symptom relief, mild as needed SABA. But now, 2019 onwards, I hope you read the latest GINA guidelines. It will tell you that low-dose ICS plus formoterol would be the drug of choice even for as-needed symptom relief, okay? They do not recommend using SABA alone. Studies have shown that it makes the prognosis much worse as compared to when you use your steroids, okay? So, for the longest time, binawi nila yung kanilang statement na SABA lang, okay? So, nakita nila na the outcome, there's increased mortality, morbidity, hospitalization if you use SABA alone. So, dapat every time gagamit ka ng SABA, o nari, mga mild attack as needed, dapat meron siyang kasamang inhaled corticosteroids. And for adolescents, ito yung recommendation nila, inhaled low-dose ICS plus formoterol. Okay? So, preferred treatment, 64% reduction in severe attack. It improves clinical outcomes. Okay? This is for adolescents, 12 years and older, and can be used for both, okay? Both maintenance and reliever therapy. Okay? So, please remember that. Okay? So, short-term use of OCS is also recommended, prevents progression, reduces emergency room referrals, prevents early relapse, and reduces morbidity. Okay? SABA alone is no longer recommended. Tinanong to sa exam before, what are the modes or methods of delivering your inhalers, your medications for asthma? And you have several. You have your nebulizer, you have your metered dose inhaler, yun yung mga puff, and your dry powdered inhaler. Okay? So the description, the images, and the pros and cons are there. Depending on the age and capability of your patients. Okay, for 0 to 3, the preferred device is your metered dose inhaler plus a spacer with face mask. Okay, 4 to 5, spacer with mouthpiece. Okay, alternative is your nebulizer, or for 4 to 5, you can use your metered dose inhaler with spacer or nebulizer with mouthpiece or face mask. Okay, so do not confuse the maintenance of asthma from treatment of asthma in exacerbation. This flowchart here shows you the treatment of asthma in exacerbation. Okay, so if you have a patient in exacerbation, so for example, mild to moderate siya, talks in phrases, prefers sitting, okay, fast RR, pero okay pa yung SATs niya, okay pa yung PEF. The treatment is to give your salbutamol 4 to 10 puffs via spacer every 20 minutes for 1 hour. Okay? Or you can also give your salbutamol nebulization Q20 minutes for 1 hour and start your steroids. Okay? Start your steroids kasi inaatake yung pasyente mo eh. Okay? If your patient, okay, is in severe or life-threatening is drowsy, confused, okay? Silent chest meaning takipnik pero wala, pagod na siyang huminga. Or severe. So, agitated, tachypnic, tachycardic, desaturation, PEF is less than 50%. You do the same, pero there's an urgent referral, okay, dapat. And the one that is preferred here, kapag severe or life-threatening, is not just SABA alone, but SABA plus ipratropium bromide. Okay, so you give SABA plus, yun yung difference. Ito, SABA alone, ito, SABA plus ipratropium bromide. And then, of course, other treatment such as oxygen support, hydration, okay? And then, of course, systemic steroids pa rin. So, strictly speaking, pag kayo ng difference ng gamot, pag mild to moderate, SABA, steroids. Ito, SABA plus yung ipratropium yung nadadagdag. Okay? SABA, steroids, O2. Alright? And then you reassess the patient. Okay? Criteria for discharge are the following. Okay? Nag-improve siya, hindi na niya kailangan ng SABA. Okay? PEF is 60 to 80%. O2 SAT is 94 room air. Okay, you have the resources to monitor. Okay, and then what do you do? Continue as needed. Kung wala pang controller, start the controller. Kung may controller na siya, adjust or step up. Your steroid should be given for 5 to 7 days, and you have to do close follow-up for these patients. Okay, hope that is clear. 10-year-old, nagkaroon siya ng 4 days fever. 36, sabi natin, 10 years old, pataas, dapat hanggang mga 20 lang yan. Okay, so tachypnic, O2 SAT 95 pasok pa. PCR positive yung mother, malamang positive din yung bata. How would you classify this? Okay, tachypnic, O2 SAT 95 room air, 4-day cough and cold. This is considered as COVID moderate, and I think they will ask this in the exam because we are just going out of the pandemic, di ba? So, these are the criteria. Mild disease is patients without pneumonia, okay? Meeting the case definition for COVID-19 without evidence of viral pneumonia or hypoxia. So these are, if I'm not mistaken, from PhilHealth guidelines, okay, DOH and PhilHealth, okay? Moderate disease is signs of non-severe pneumonia, pero meron siyang tachypnia, okay? Cut-off nila is less than 2 months, 60, 3 to 12 months, 50, 1 to 5 is 40, and then 6 to 10 is 30, more than 10 is 20, okay? So, yan. Moderate disease is clinical signs. Ito yan. So, dinagdagan natin yan. Oh, sa kanila pala 12. So, yung ibang guidelines hanggang 10 eh. So, for this COVID guidelines, 12 yung cutoff nila ng 20. Okay? And of course, radiographic finding of pneumonia. So, either chest x-ray, kung wala, you can do CT scan, ultrasound, other radiographic findings. Okay? Severe, okay, kapag meron kang pneumonia and at least one of the following cyanosis, desaturation, indrawing, grunting, fast breathing, okay, inability to feed, seizures, convulsions, unconsciousness, okay, yeah, and that's it, okay. So please remember these important classifications for pneumonia, and if you will see, very much similar to the classification of PCAP in children, so pediatric community acquired pneumonia, not exactly the same, pero halos parehas lang, okay. R2-PCR versus rapid antigen, when to do the test, baka tanungin din kayo. I've highlighted the most important parts there in red. So, of course, RT-PCR is the gold standard. You can do it shortly or at the onset of illness. If asymptomatic, you do it 5 to 7 days after exposure. And ito tinatanong din, how do you screen neonates? Okay? We test at 24 hours and then repeat at 48 hours. Okay? What about antigen? Can you do it as soon as the symptoms develop? Okay? So ideally, sabi, during the early phase, equal or less than 7 days from the onset of symptoms. Pag mas matagal na, baka negative na yan. Okay? But its use is actually to confirm the close contacts in COVID-19 when PCR is not immediately available. So ideally, PCR pa rin. Pero if you want to confirm close contacts during outbreaks, remember that term, during outbreaks. So ngayon, wala na tayo sa outbreak, okay? It's not actually recommended to test contacts with antigen kasi mataas ang kanyang false positivity. Okay? So a negative antigen test should be confirmed with your PCR. Kailangan mo i-confirm yan. Lalo na in settings where COVID-19 is highly suspected. And in my experience, we've had a lot of patients na negative antigen tests, pero mukhang COVID talaga, may exposure siya. When we do the PCR, lo and behold, COVID nga talaga siya. Alright? Antibody is almost outdated. Please take note, it's not used for diagnosis of acute infection. It is also not recommended to determine immunity. Okay? Might have a use in the workup for your MISC-C, one of your complications of COVID-19 in children. Okay? 10-week-old male, so medyo bata, 10-week-old. Persistent cough, okay? 9 days na, so more than a week, okay? Pero walang fever, okay? Alert, R of 45, 10 weeks old. So mga 2-3 months, 45, pasok pa. Occasional fine rals on x-ray, hyperinflation with mild diffuse infiltrates. So you have a pneumonia here. Most likely, what organism will you think of? Neonatal period. Relatively young patient, more than a week of cough and colds. Mukha siyang benign, pero may pneumonia siya on x-ray, may symptoms siya. This is typical textbook presentation of your chlamydia trachomatis pneumonia. Okay? So it affects your infants 1 to 3 months. Okay? Prolonged cough and congestion, no fever, and on x-ray you can have infiltrates and consolidation. Source likely is the mother. Treatment is your macrolides, erythromycin or azithromycin, or you can also give your clarithromycin. Okay? 7-year-old boy presents with a 4-day history of cough, colds, high-grade fever, and brassy. So, itong mga keywords na yan, na-discuss yan, I'm sure in detail ni Doktora Punong Bayan. Mayroon kayong mga brassy cough, staccato cough, meron kang mga whooping cough, ganyan. Okay? So, brassy cough, and on lateral x-ray, meron kang pseudomembrane detachment on the trachea. Okay? So, pag pseudomembrane na nakikita mo dun sa throat niya, sa pharynx niya, pag nag-PE ka, that's your diphtheria. This one, pseudomembrane detachment on x-ray sa trachea. Okay? And clinically, this patient is usually toxic looking, high fever, respiratory distress. Okay? What particular finding would you expect in this patient? Okay? So, musical sound, mainly in inspiratory timing, mukhang hindi yan. Minimal clear secretion upon expectoration. Hoarseness is out of proportion to the other symptoms. This can be findings, pero ang pinakamagandang sagot dyan would be your thick, copious, and purulent secretions, because actually from the x-ray finding alone, you would know that this is a case of your bacterial tracheitis. Okay? So this is bacterial tracheitis. So it is commonly caused by Staphylococcus aureus, and most of the time, children with bacterial tracheitis, they are toxic looking. Spasmodic croup is in your handout. It's one of the diseases that is usually compared with bacterial tracheitis. However, guys, to be honest, okay, medyo malayo yung dalawang sakit na yan. Spasmodic croup is usually benign. Pwede siyang viral in origin, pero most of the time, it's an allergic response. Whereas bacterial tracheitis is more toxic, bacterial in origin. And in x-ray, you look for that pseudomembrane detachment from the trachea. Okay, so here in this table, very important, very useful table. I have highlighted again in red the things that you really need. Age group, younger ang spasmodic croup. Bacterial tracheitis is usually older. In tracheitis, you have your brassy cough, high fever, and toxicity. Okay, in spasmodic croup, okay, you can have a prodrome, pero fever in the patient and the family are often absent. And the causes are usually viral, allergic, or even psychogenic. Okay? Symptoms is usually also nighttime in spasmodic croup. Okay? PE findings, you have copious, thick, and purulent secretions. Okay? Whereas in spasmodic croup, usually parang benign yan. Okay? Diagnosis is clinical. In tracheitis, you use your x-ray to look for pseudomembrane detachment in the trachea. Treatment is supportive, same as laryngotracheobronchitis. LTB, what do you give for your viral crew? You can give your racemic epinephrine nebulization, di ba? Whereas for tracheitis, this is infectious, this is viral, okay? Sorry. For bacterial tracheitis, sinabi naman bacterial, sinabi ko pang viral. For bacterial tracheitis, since this is bacterial in origin, and again, you're dealing mostly with staphylococcus, then you treat with antibiotics, usually vancomycin and clindamycin. Okay, vancomycin or clindamycin plus, okay, a third generation cephalosporin to cover for your gram-negative because a lot of times it's multibacterial in origin. So, hindi mo naman talaga alam from the get-go na staphylococcus lang to eh. Pero, pag tinanong sa exam, anong pinaka-common cause, then staphylococcus would be your answer. Okay? So, spasmodic crew, again, on the other hand, it's more of an allergic reaction to your viral antigens rather than a direct infection. Okay, so please remember those in red, very important. Again, drug of choice for bacterial tracheitis, Vanco or Clinda, both would have coverage for methicillin-resistant Staphylococcus aureus. The difference is vancomycin is better for hospital-acquired MRSA. For community-acquired MRSA, clindamycin would be the better choice. And again, we add third-generation cephalosporins to have that gram-negative coverage. Okay, so yan. So clinical picture, so toxic-looking patient, okay, plus absence of classic epiglottitis on x-ray, and on x-ray you see your pseudomembrane detachment. You can also have your steeple sign, similar to that of your laryngotracheobronchitis, okay? Kasi sa bacterial, sa epiglottitis, what you look for is your thumbprint or your thumb up sign, okay? Based on the 2020 NTP, National TB Control Program guidelines, which of the following is not included as a cardinal sign of your TB, okay? So, night sweats is included, unexplained fever, unexplained weight loss, yes. Failure to respond after 1 week of antibiotic treatment, it's not included. Actually, dapat 2 weeks yan, okay? So, your NTPB, please read those guidelines, very important, okay? Definition of terms, presumptive pulmonary TB, meaning any person having 2 weeks or longer, any of the following: cough, unexplained fever, unexplained weight loss, night sweats, or chest x-ray finding suggestive of TB, okay? Presumptive extrapulmonary TB, on the other hand, anyone having signs and symptoms specific to the suspected site. So, pwedeng sa brain, pag meningitis, pwedeng sa spinal cord, okay? Without general constitutional signs and symptoms. Okay, so please remember that. And I think Dr. Apunumbayang had discussed very detailed naman yung classification, specifically in children, the diagnosis of tuberculosis. Medyo kakaiba siya sa adult. So, marami tayong fulfill na criteria. Okay? What is the difference between cephal hematoma and caput succedaneum? Again, commonly asked question, basic knowledge, dapat alam nating lahat. Ano yung mas malalim, ano yung mas mababaw? Yung cephal hematoma, okay, siya yung mas malalim, okay? Yung caput succedaneum, siya yung mas mababaw, okay? So, cephal hematoma does not cross the suture lines. Tama yan. Okay? Caput succedaneum, siya yung mas mababaw. It crosses the suture lines. Mas mababaw siya. It resolves in a few days time, not weeks. Okay? Cephal hematoma presents as diffuse swelling of the scalp. No. So, yun nga, hindi siya diffuse kasi yung mas mababaw, yun yung caput succedaneum. Okay? And newborns with caput undergo hyperbilirubinemia. Actually, no. Hyperbilirubinemia is more common in the deeper-seated bleeding, which is your cephal hematoma, or pwede rin sa subgaleal hemorrhage. Okay? Okay. So, yeah, there. I've said it all. Andyan na yan. So, those are the differences between your cephal hematoma and your caput succedaneum. Which parameter of the Apgar score is last to disappear in a very sick, dying newborn? Ano yung pinakaunang bababa? Okay? Bago pa bumagsak yung heart rate, okay, nag-iba na yung color niyan, nag-iba na yung tone and activity, nag-iba na yung respiration. Kasi yung cardiac rate, yan yung pinaka-last. Ibig sabihin, ang tagal mong hindi na-address yung concern ng bata. Pag binagsakan ka na ng heart rate, papunta na yan sa cardiorespiratory arrest. Okay? What is the order of disappearance in a sick baby? So, ayan, mauuna yung color, respiration, tone, reflex, and then cardiac rate. At the same time, pag nagre-resuscitate ka, yung cardiac rate ang unang tumataas at nag-i-improve. So, you know you're doing it right kapag tumaas yung cardiac rate mo, gumanda respiration, tapos nag-improve yung color ng pasyente. Okay? 28 weeks of gestation, nag-start ng nasogastric feeding. 2 weeks old na siya. So, medyo nakatawid-tawid na to siguro sa pinagdaanan niya kasi nag-feed na sila eh. Pero after feeding, lumaki yung tiyan, naging bloody yung stool. On x-ray, what do you look for? And again, I told you this, classic to. Stormy course, preterm newborn, lumalaki yung tiyan, nagtotoxic siya right after feeding. Okay na siya pero nung pinakain, nagtoxic ulit siya. This is a case of pneumatosis intestinalis, okay? It's actually not a case of pneumatosis intestinalis. The answer is pneumatosis intestinalis because this is probably a case of your necrotizing enterocolitis. Okay, your neck. So, I've discussed this again, very detailed in our lecture. So you have your triad, your ischemia, enteral nutrition, which will serve as a substrate para sa pathogenic organisms. Ano mga pathogenic organisms? E. coli, Klebsiella, Proteus, mga enteropathogenic organisms. Okay? Age of onset is proportional to the gestational age. The more premature the baby is, the higher chances of developing neck. Okay? So, mas common to sa mga preterm babies. And a lot of them will present with bloody stools plus or minus other signs and symptoms of gastrointestinal instability. Okay? X-ray pneumatosis intestinalis is suggestive, but please remember it is not pathognomonic. It's suggestive, but not pathognomonic. Okay? So, ano ba yung pneumatosis intestinalis na yan? Yan yun. So, air in the bowel wall. So, thickened bowel walls na may air sa gitna. So, that is your pneumatosis intestinalis. Okay? Which of the following is not a physiologic condition in the newborn? Okay? So, of course, the answer is obvious. Hindi natin kailangan pagtagalin yan. So, it's subgaleal hematoma because that is definitely not physiologic. It's a pathologic finding. Okay? Which milks? Nagkakaroon sila ng gatas. Gulat na gulat yung bata. Sabi niya, oh, ako yung nagbe-breastfeed. Bakit may sarili akong breast milk? So, that is what you call your witch milks. Okay? Orange staining urine. You see that a lot. Those are your urates. Okay? So, pag hindi pa ganun ka-establish yung urine output and kidney function ng babies, kung minsan nagkakaroon sila ng urate sa kanilang wiwi, we just observe and reassure. Usually, walang ginagawang problem dyan. In females, sometimes in males, I've seen cases in males too, kung minsan nagkakaroon ng mga bloody discharge na ganyan, okay lang yan. No-observe lang din yan. As long as the baby is okay, there's no fever, there's no other problems, then you observe and reassure. Subgaleal hematoma, on the other hand, it's actually one of the worst among the three. Okay, yung scaput, succinium, yung cephalohematoma, saka subgaleal. Yung subgaleal, yung pinaka-worst. Okay? So, there's bleeding in your emissary veins, okay? And the blood collects beneath your aponeurosis and it can extend. Pwedeng umabot sa batok, pwedeng umabot sa muka. Nagkakaroon sila ng raccoon eyes. So, ito yan. So, that's your subgaleal hematoma. And again, among the three, it's the most toxic. And I've seen several cases of subgaleal hematoma. And unfortunately, I think majority of those cases, hindi nakakalusot yan. So, very complicated disease condition. And fortunately, hindi rin siya ganun ka-common. Okay? Full-term 6-day-old, G1P1 with jaundice until the thighs, purely breastfed, okay? Walang other abnormal symptoms. Nagpa-check ng bilirubin 17, mataas yan, okay? Although sa 6-day-old, again, you have to refer to the Botany chart. Pero tapos recently, noong 2020, if I'm not mistaken, meron silang revisions na ginawa dun sa chart for phototherapy ng bilirubin levels. But that's for another day. Medyo mas ano yan, higher level information yan. So for the board exam, so ito tayo, mataas 17, reticulocyte count is elevated, may spherocytes ka, okay? Coombs test positive, baby is a mother's or what is most likely your diagnosis, and that's a dead giveaway. OC mother, A or B or ABC baby. Coombs test positive, meaning there's hemolysis that is probably autoimmune or immune hemolysis. Then this is ABO incompatibility. Okay? Neonatal jaundice. I have upgraded this table. This one is from Nelson's. You do have older charts and reference from your handout. And that is still applicable. Pero word for word, copy-paste ito yung galing sa Nelson's. How do you know if the jaundice in the newborn is physiologic? The criteria is this. Dapat indirect yung mataas, okay? Appearance in full term, 2 to 3 days siya lumalabas. In preterm, 3 to 4 days of age lumalabas. So definitely, jaundice in the first 24 hours is not physiologic. Okay? Sabi dito, dapat in full term, mawala siya in 4 to 5 days. In preterm, 7 to 9 days. Okay? So general knowledge, again, I put it there. Actually, physiologic can be up to 2 weeks or 14 days. Okay? Peak concentration, ito, tinatanong to, for full term, it's 10 to 12. For preterm, it's 15. Kaya mataas yung definitely yung 17. And the rate of accumulation is also important. Dapat hindi siya tumataas by more than 5 milligram per deciliter in one day. Okay? So sabi din ni Nelson's, you search to determine the cause if any of the following is present. Okay? So pag present yan, malamang pathologic yan. First 24 hours, more than 5 per day ang increase, more than 12 in full terms, more than 10 to 14 in preterms, and anytime that your direct bilirubin is more than 2 milligram per deciliter. Okay? And again, different guidelines will tell you different things, but for the board exam, Nelson's tayo. Kasi sa AAP, ang cut-off nila dati was 20%. Ngayon, binago na rin nila, hindi na 20%. Okay, bahit pumataas ang direct bilirubin, it is always considered pathologic because that can be a sign of cholestatic or cholestasis, cholestatic jaundice. Okay? So most common cause of hemolytic disease in the newborn, not all patients will develop hemolysis, but if they do develop, usually there's set up the mother is O, the baby is either A or B. Most cases are mild, some are severe, which will require management. Management for these patients is phototherapy, if severe, IVIG or exchange transfusion. Okay? So other lab tests is spherocytes, pwede ka magkaroon ng some degree of anemia because of the hemolysis, mataas yung reticulocyte count, and of course, your bilirubin will increase. Sabi dito, indirect or B1, yes, but again, in newborns, we look at the whole picture, we look at the total serum bilirubin. RH incompatibility, again, important to note for RH is it rarely occurs during the first baby dahil kailangan mo pa magkaroon ng sensitization. Ang usually tinatamaan is yung subsequent, second, third, fourth, onwards. Management is to give your ROGAM, okay, immediately after the delivery, okay, of each RH positive infant, okay? So, again, difference between breastfeeding and breast milk jaundice, I have discussed this in detail. As a quick review, mas maagang lumalabas ang breastfeeding, mas nahuhuli yung breast milk jaundice. Ang problema sa breastfeeding jaundice is usually lack of calories, so the management is to increase your feeding and the intake of milk. On the other hand, breast milk jaundice is later in appearance, okay, can last for up to 3 months, considered still physiologic, okay. Factor is probably because of the glucuronidase, although technically speaking, it is idiopathic. Hindi pa rin alam kung ano yung nagkakos ng breast milk jaundice. Okay? Management is to stop if needed. Hindi lahat kailangan mag-stop, but for those with very high levels of bilirubin, you can stop and probably consider giving formula milk. But for most patients, again, observe lang yan. Okay? So, to reduce the incidence of breastfeeding jaundice, and sabi na natin yan, breast milk jaundice, nasabi na rin natin yan. Alright. Okay, 7-day-old breastfed full-term baby boy. Nagkaroon siya ng fever and decreased suck. So, papasok pa to sa early onset sepsis, di ba? 7 days, okay? Actually, 7 days, no? Papasok na pala sa ano to? Sa late onset sepsis to. No other signs and symptoms. Nagkaroon siya ng UTI, pero hindi niya na-complete yung meds. And you have leaking of your water for more than 20 hours. Ang significant cut-off natin is 18 hours lang. So, pasok lahat siya for the risk factors of neonatal sepsis. What is the most common etiology for patients like this? Of course, is your BEL. Nabanggit natin yan a lot of times. Group B strep, E. coli, and Listeria monocytogenes. Okay, so let's letter B. Okay, so please remember, early onset sepsis is first week of life. 7 to 30 days is late, and very late is after 30 days. Pinaka-important na risk factor is maternal infection, prolonged rupture of membranes, and of course, prematurity. Pag tinanong kayo, anong pinaka-important anong pinaka-important na risk factor for neonatal sepsis? Tapos nandito lahat to, ABC, ang sagot, prematurity pa rin. So, prematurity ang isa sa mga pinaka-important na risk factor for neonatal sepsis. Okay? E. coli, GBS, Listeria. Sabi na natin yan. 30-week-old baby girl, 1.8 kilogram, increased breathing on her second day of life, Apgar 7-9, tachycardic, tachypnic, desaturation. Most likely, what is the cause? Okay? preterm, maliit na baby, respiratory distress. First differential in mind would be, ano ba yung respiratory distress early onset in preterm patients? That is your respiratory distress syndrome, your hyaline membrane disease, and the pathophysiology is decreased production and secretion of your surfactant. Again, very important to reduce the surface tension in your alveoli. Okay? So, deficiency or immaturity of your surfactant. Okay? Sabi na natin yan. So, transient takip niya, other choices in this question. Slow absorption of fetal lung fluid that is transient. Takip niya, persistence of your fetal circulatory pattern. So, hindi nagsara yung mga shunts. That is your persistent pulmonary hypertension. Okay, PPHN. 12-day-old full-term breastfed baby, G1P1, bleeding from the umbilical stump. Pinanganak sa bahay. Pero syempre, hindi sinabi dyan. Most likely, what will you think? You think of your vitamin K deficiency, and in newborn, it's your early onset VKDB. Vitamin K deficiency bleeding. Okay? Which is an incorrect practice in your EINC, Essential Intrapartum and Newborn Care. Ano yung incorrect dyan? It's, okay, non-separation, 20 to 60 minutes. Tama. Early skin-to-skin contact. Tama. Drying the baby after birth. Tama. Cord clamping within the first minute of life. Among the choices, ito yung pinaka magandang sagot. Technically, it's within first 3 minutes. Okay? You wait for 1 to 3 minutes. Okay? Or until the pulsation stops. Bakit sinabi ko ito yung pinaka-best na sagot among the choices? Kasi technically, okay, kung 50 seconds yan pero wala na siyang pulsation, then technically pwede mo na actually siyang i-clamp. Okay, so please remember that. Okay, so when do you clamp? Delayed cord clamping, 1 to 3 minutes. Okay, 1 to 3 minutes, or until the pulsation stops, whichever comes first. Okay, whichever comes first. So kunwari, 3 minutes na may pulsation pa rin, pwede mo na siyang pwede mo na siyang i-clamp. So again, immediate drying, skin-to-skin, cord clamping, non-separation of the baby and the mother, delayed cord clamping 2 to 3 minutes after birth. Okay, so it decreases the incidence of anemia and intraventricular hemorrhage. Okay, 2-day-old baby girl, 1.3, premature siya, maliit. Okay, pangit yung Apgar score, hypotensive, very toxic. On cranial ultrasound, meron kang bleeding within the ventricle but without dilation. Okay, what is your grading? Tinanong to. I remember tinanong to mga 3 or 4 years ago. This is a very unfair question. This is a resident consultant level question. But, tinanong siya. Okay, pag lumabas, pag ganyan, idadasal ko na lang yan. Siyempre, alamin natin yung sagot, okay, for the sake of learning. It's grade 2, IVH, okay? So, intraventricular hemorrhage, there's a lot of causes. Usually, pag may trauma or asphyxia yung bata, yung pinaka-common dyan is asphyxiated newborn. So, yung mga newborns na pangit yung Apgar score paglabas, nagkaroon sila na asphyxia, hypoxia, okay? And prematurity, of course, another, again, risk factor, laging risk factor ang prematurity, okay? And here's the grading. Actually, madali lang siyang tandaan. Subependymal is 1, okay? Intraventricular without dilatation is 2, intraventricular with dilation is 3, and parenchymal is 4. Okay, so yun lang tatandaan nyo. Subependymal, intraventricular, intraventricular with dilation, tapos parenchymal hemorrhage. So yun yung 4 na grading ng IVH. Okay? Full-term baby is born to a mother who is positive for hepatitis B surface antigen. What do you do, okay, for this baby? A, hepatitis B vaccine lang. B, mag-obtain ka muna ng liver function test. C, HBIG, immunoglobulin. Bibigay mo raw siya kay baby if the baby is positive for HB-Sag. So sabi niya, i-check mo muna si baby kung positive siya sa HB-Sag. Or D, bigay ka ng vaccine and immunoglobulin. The answer, of course, is letter D. All know this by now. Okay? So dapat, kapag HB-Sag positive yung mother, paglabas ni baby, within 12 hours, okay, dapat may vaccine plus immunoglobulin na yan. Okay? Kung wala kang IG, hindi kasi siya readily available, katulad ngayon, 2023, there's a shortage of your Hepa-Big. Anong gagawin? Actually, you have 7 days. You can give it within 7 days. Vaccine muna, tapos within 7 days, you can give your hepatitis big, your IG. 14-year-old girl, punctured wound on her left foot. Nakatapak siya ng nail. Ang sakit naman yan. Tapos na raw yung kanyang primary series nung bata siya, tapos nag-booster pa siya nung 18 months old. 18 months old, so more than 10 years na. What is the best plan? So you give your tetanus toxoid alone. This is your guidelines. Again, remember, IG guys, sobrang dalang binibigay niyan. Okay, so again, rundown, okay? You give your prophylaxis, ang tatanungin nyo, nakailang dose ba yan, saka clean ba siya or hindi. Okay? Kasi pag naka more than 3 na yan, okay, at clean wound yan, magbibigay ka lang pag 10 years na yung last booster. Kapag hindi siya clean wound, pero naka more than 3 na siya, 5 years ang duration natin. Okay? Pag unknown or less than 3, toxoid. Okay? Toxoid yan. Okay? Kailan ka lang nagbibigay ng IG? Pansinin nyo yung IG. No. So, bihirang-bihira ka nagbibigay ng IG. Nagbibigay ka lang ng IG kapag less than 3 or unknown. Okay? And hindi siya clean wound. Doon ka lang nagbibigay ng IG. And, idagdag nyo pa dyan, kapag HIV patient. Okay? Which of the following is not a live vaccine? Okay? Again, memorization work lang to. It's your Hib. Varicella, MMR, rotavirus, dahil kakaiba yung route, di ba? Sub-Q, oral, yan yung mga live vaccines. Hib is IM. IM malamang, sabi natin, pag IM yan, by mnemonics of Doc Ian, by rule, pag IM yan malamang, inactivated yan. So again, you cannot do anything about this, simply memorize. Memory work lang mga yan. Pero yun nga, sabi ko sa inyo, pag hindi yan IM, ito yung mga malamang live vaccines. Okay? 6-year-old, superficial abrasion on her left leg while playing with her pet dog. Hinugasan, sinabunan, in-induce ng bleeding. How do you categorize this patient? Dok, dumugo, pero in-induce naman. This is still category 2. Unless nakagat siya sa head and neck area. Pero sabi dito, saan siya nakagat, saan siya nagkaroon ng abrasion? Sa left leg lang. So, category 2 lang yan. Okay? So, again, remember the description. Touching, feeding, licking, nag-inarte lang. Okay? Nibbling, minor scratches or abrasions without bleeding. Okay? Punctured licks on mucous membrane with saliva, wounds on head and neck, wounds with bleeding. That is category 3. Post-exposure measures, it will actually depend on your immunization status. Depende kung dati na siyang nabakunahan, immunologically, meron na siyang protection, or kung wala pa siyang previous protection. So, dun magde-depend yun. Okay? Baka hindi nyo nag-gets. O, balikan natin ha. Parang yung iba dyan nagtanong. Guys, your post-exposure will depend on your immunization status. Kapag immunologically naive ka, wala ka pang previous vaccine, okay? Category 2, anong binibigay? Category 2, nagbibigay ng vaccination. Category 3, vaccine plus immunoglobulin. Okay? Pero pag hindi ka na naive, ibig sabihin, nakapag pre-exposure prophylaxis ka or nakagat ka na before and nabigyan ka na ng course ng rabies vaccine na kompleto, ibig sabihin may protection ka na, booster na lang yan. Pag category 2, booster day 0, day 3. Pag category 3, booster lang din, day 0, day 3. Wala ng immunoglobulin. Okay? Malinaw yon. Nag-i-immunoglobulin lang tayo for category 3 who are immunologically naive. Wala pa siyang PrEP or wala pa siyang na-complete na post-exposure prophylaxis. Hindi pa siya nakagat before. Okay? Pero kung nakagat ka na before, paulit-ulit, pero kailangan idikdik to dahil lagi lumalabas sa exam. Dok, nakagat ako noong 2020, nakompleto ko po yung recommended post-exposure, PEP, post-exposure prophylaxis. Na-complete ko na noong 2020. Nakagat ako ulit ngayon. Category 3 ulit. Lumabas yung bituka ko. Ang laki nung kumagat sa akin. Ano ibibigay ko? Nakakompleto ko na before eh. Nakakompleto ko na ng vaccine before. Booster na lang tayo ngayon. Wala nang immunoglobulin. Kahit pa, category 3 yan. Okay? Child prefers to use his right hand in picking up objects. Runs stiffly. Tigas tumakbong ganun. Okay? And is beginning to climb steps. 15 words, can feed himself with a spoon. What is your developmental age? Definitely not 10. Okay? Pag ganitong developmental milestone, cross lang tayo dyan. Definitely not 10. Okay? 15 words, medyo marami na yan. First year of life, mga 5 words lang yan. 10 to 15, papuntang second year na yan. So, 15 months might be out. You're left with 18 months and 24 months. Okay? So, between the two, medyo stiff pa yung pagtakbo niya. Hindi pa siya nakakaakyat masyado. The better answer would be your 18 months old. Okay? So, again, remember, growth and development, it's actually a spectrum. Okay? And it's a range. Kaya I, for once, myself, I think that growth and development questions are a bit unfair unless yung talagang mga general knowledge katulad ng tooth eruption, turning over, first word, ganon. Okay? Anyway, that's just me. Saka napag-examiner na ako. Number 47. What is the first carpal bone to appear in the x-ray showing its center of ossification? Memorization lang again. It's your capitate. Okay? Kasi yan daw yung appearance of the x-ray centers of your baby. So, capitate, hamate, yan. So forth and so on. Doon, kailangan mo namin i-memorize. Guys, lumabas to before eh. Siguro mga 5-6 years ago. Okay, and how do you attack that? You simply have to memorize. Do I have a mnemonics for that? Wala. Pag nilabas sa akin yan, kung ako yung nag-exam nun at nilabas sa akin yan, idadasal ko na lang yan. Of course, 1 point is 1 point. So, yeah. If you have extra time in studying, might as well memorize it. Okay, ito dapat masagot natin to. First tooth to erupt in a child, it's your central mandibular incisor. So, mandibular sa baba, central incisor. Okay? 16-year-old, anorexia nervosa, 40% weight loss. So, hindi siya kumakain ng maayos, may anorexia siya. Tapos, irritable and depressed, diarrhea, rashes, dermatitis. Okay? Nagka-crack na yung balat niya, makapal na siya. Tapos, irritability and confusion. What vitamin deficiency is suspected? Again, it's going to be a multiple gamut of micronutrient deficiency. Bihirang-bihira yung isolated lang. Kasi ang dami mong nutrient deficiency. Pag suka namamayad ka, malnourished ka. But for the purposes of the board exam, you have to know how these deficiencies present. And this is very obvious. Diarrhea, dermatitis, dementia. Diba? Irritability and confusion. And anong susunod dyan? Death. What are the 4 Ds? That's your mnemonic for pellagra, your niacin, your vitamin B3 deficiency. Diba? Dermatitis, diarrhea, dementia, and death. Okay? Thiamine is berry, riboflavin, sabi ko sa inyo, non-specific yan. Vitamin A, think of your eyes. Okay? Eyes. So, yun yung mga problema nyo. Like vision, blindness. Okay? Right. Which of the following is not a manifestation of marasmus? Anong ulit yung mas toxic? Marasmus or kwashiorkor? Anong sabi ko sa inyo? Mas mahirap bigkasin, mas mahirap i-spell ang kwashiorkor. Yung kwashiorkor ang mas toxic. Okay? So, which of the following is not, okay, not a manifestation of marasmus? Okay? Starvation type ba ang marasmus? Yes. Ang marasmus wala siyang makain, di ba? Versus kwashiorkor ang kulang sa kanya protein. Wrinkled and loose skin, yes. Marasmus is your old man fasces. Atrophy of muscles, di ba? Naminipis yung mga muscle niya, okay? Hypochromatria, kulay, nawawalan ng kulay yung mga buhok. So, hypochromatria is more of a finding in kwashiorkor. Okay? So, again, please remember, okay? Please remember the difference between kwashiorkor and marasmus. Again, my tip for you, kapag positive attribute yan, mas maganda yung appetite, okay? Wala siyang fatty liver, mas mabilis bumawi, wala siyang neurological manifestation most of the time, then probably that is marasmus. Mas toxic si kwashiorkor. Okay? Lethargy, apathy, inadequate growth, okay? Loss of muscular tissues, susceptibility to infection, edema. Yeah, that is kwashiorkor. Okay? Halfway through, 51. Which of the following differentiates hind milk from foremilk? So, yung unang lumalabas na gatas versus yung nahuhuli. Remember, yung isa dyan mas malapot, yung isa mas malabnaw. Pag pinagsama mo sa isang mixture yung dalawa, tingin nyo ano yung mas unang lalabas. Of course, yung mas malabnaw. Okay? Yung mas malapot, mas maiiwan siya. Okay? So, mauuna yung mas malabnaw, which is your foremilk. Yung mas malapot, mahuhuli siya. And the question is, bakit malapot yung malapot? Bakit malapot yung hind milk? Okay? And the answer that is because of the fat content. Mas mataas ang fat content nung hind milk, yung nahuhuli. So, hind milk has more fat. Okay? Foremilk, on the other hand, will have more protein and lactose content. Okay? And again, hind milk will be more fatty. Okay? Hindi siya watery, more fatty siya. So again, foremilk is watery, lactose and protein. Hind milk is creamy, higher fat content than foremilk. Okay? So please go back to our nutrition lecture and review. Mabuti yung mga composition ng breast milk. Okay? 15-month-old severe diaper rash, okay, resistant to treatment, difficult to treat rash, difficult to treat dermatitis, okay? Loose stool, diarrhea, okay? Tapos meron din siyang scaly corners at the mouth. So yung mga ano yan, ano tawag ito? Chelosis and glossitis, okay? So, okay, mother breastfed her and ngayon kaka-switch lang niya sa cow's milk, okay? So 12 months of age. So, 3 months ago, nag-shift siya to cow's milk and then dun lumabas yung mga problems niya. And what would you think that is? Okay? Kulang na lang dito, sinabi, kung nagpa-test kayo ng alkaline phosphatase, mababa. Okay? Because this is your acrodermatitis enterohepatica. That is your zinc deficiency. Okay? So, common siya sa mga kaka-wean off because breast milk has a ligand which enhances zinc absorption. So, pag hindi na siya nag-breast milk, hindi siya breastfeed, mas bumababa yung zinc absorption, mas lumalabas yung manifestation ng acrodermatitis enterohepatica. Again, the differential diagnosis if you have patients with difficult to treat dermatitis. Okay? Other choices in the question, iron is causes iron deficiency anemia. So, anemia ang manifestation niya, microcytic hypochromic. Vitamin C, think of scurvy. Vitamin E is an antioxidant. Deficiency of vitamin E would cause hemolysis, thrombocytosis, and hemolytic anemia. Alright. 8-year-old male, meron siyang murmur and dusky blue skin. So you know that the patient probably has a congenital heart disease and dusky blue skin, probably cyanotic. Okay? So again, di ba, pag meron kang CHD, ang unang mong tanong, cyanotic ba siya or acyanotic? Okay, clubbing of the fingers, which signifies na matagal na to and a hematocrit of 70%. So this is polycythemia as a compensation for the anemia. For the hypoxemia, okay? Meron kang 4/6 regurgitant murmur at the left lower sternal border with a loud single S2, okay? Decreased blood flow and upturned apex, okay? Most likely, what is your diagnosis? So, among your congenital heart disease na cyanotic, ano bang pinaka-common? The top one is TOF. So, if you're just gonna focus on that, then your answer would be TOF, and indeed, the answer is TOF, okay? However, let's look at the other parameters given in the question to support your diagnosis. Talaga nga bang TOF yan? So, hematocrit, polycythemia, that's a finding. What about the murmur? Ano ba yung murmur mo ng TOF na naririnig mo? Diba? In TOF, you have your pulmonary stenosis, you have your VSD, overriding aorta, and right ventricular hypertrophy. So, VSD, what's the murmur of the VSD? And precisely, that is the murmur of your VSD is your regurgitant murmur as the left lower sternal border. Okay? If you do your review and you look at the patterns, and I think I will be discussing this in a special lecture, if I'm not mistaken, but anyways, if you have a regurgitant murmur in the left lower sternal border, okay? Left lower sternal border towards the apex, kung regurgitant yung murmur mo, ang differential diagnosis mo lang dyan can be narrowed down into 3. VSD, okay, mitral regurg or tricuspid regurgitation. VSD is congenital, mitral regurgitation is rheumatic heart disease unless proven otherwise, and tricuspid regurg is not that common. So, yes, that is indeed the murmur of your VSD. Okay? Decreased pulmonary blood flow on your X-ray, yes, because of your pulmonary stenosis, di ba? Meron kang right ventricular outflow tract obstruction. So, please take note, that is your tetralogy of Fallot. The mnemonics on the component is your PROV, P-R-O-V. And you see an upturned apex or a boot-shaped heart. Okay? 2-year-old female with TOF, difficulty of breathing dahil hindi siya pinaglaro, nag-brat siya. Siyempre, ganun yung bata. Di ba? Umiyak siya. However, pag iyak niya, nagtuloy-tuloy, nag-cyanosis na siya, nag-tachycardia siya, hingal siya, hyperpnea, and mag-downhill yan from there. So this is what you call your TET spell in patients with TOF. And what is the appropriate management? The initial appropriate management is, of course, to put the child in a knee chest position to decrease your systemic venous return and increase your systemic vascular resistance. Huwag pagpapalitin yung dalawang yun. Okay? So, TET spell or your hypercyanotic paroxysmal attack. This is your hypoxic spell. It is triggered by your catecholamine release. Okay? And also triggered by activities that lower your systemic vascular resistance. Okay? Tataas yung cyanosis. Pag nag-cyanotic siya, mas magiging takipnik siya. Pag nagtakip niya siya, magkakaroon siya ng acidosis, tapos hindi magiging maganda yung circulation, so forth and so on. Magkakaroon siya ng cycle of the vicious problem which will lead to your death spell. Okay, and how do you abolish the death spell? It's by putting the child in a knee-chest position, giving oxygen, pag-acidotic bicarbonate, morphine to decrease the irritability and the takip niya as well. Alright? 3-year-old has a history of recurrent pneumonia, failure to gain weight, continuous murmur. That's a giveaway. Pag may continuous murmur ka on your second left ICS with bounding pulse, wala nang ibang sagot. This is your patent ductus arteriosus. Okay? Again, it's more common in preterms. Okay? However, in preterms, do take note that your PDA in preterms can respond to medical management. So, pwede kang magbigay ng ibuprofen, paracetamol, mga may isang binibigay, indomethacin, if I'm not mistaken. Have to check on that. But basically, preterm PDA will respond to treatment, okay? Kasi ang problema mo lang dyan, yung mga receptors mo para magsara yung PDA, as compared to a full-term PDA, which most likely the management will be surgical, okay? So, you have a significant pressure gradient both in the systole and the diastole. That's why you have a shunt in both cycles. That's why your murmur is continuous machinery-like, okay? So, please remember that. You see a 12-week-old male, so 12 weeks, that's 3 months, okay, with cough and poor feeding, tachycardic, tachypnic, 3.5 kilos for a 3-month-old male, mababa yan. Okay, diffuse crackles with a 3/6 regurgitant murmur at the apex. Sabi ko sa inyo, malamang sa malamang, VSD yan. Okay, which of the following condition is most likely the cause of his pneumonia, tachycardia, tachypnea? Probably that is VSD. Okay, so remember, for VSD, you have your left ventricular hypertrophy most of the time because it's the left ventricle that does the volume of the work. Okay, kasi your shunting occurs in the level of the ventricle during contraction. So yung blood na pupunta sa left, kailangan niya ipump papunta sa aorta. Okay, small VSD will have normal growth and development, and most of the times asymptomatic yan. Most of the time, depending on the type of the VSD, it can close on its own. However, moderate to large will cause problems such as delayed growth dahil hindi naging efficient yung heart, yung energy ng katawan na pupunta dun sa nag-overwork na heart, okay? Decreased tolerance, repeated infection, there's congestion as well. VSD will present with increased pulmonary blood flow and congestion. And again, regurgitant murmur at the LLSB, okay? A treatment of choice for the prevention of rheumatic fever. Okay? So again, pwedeng umulit-ulit ang rheumatic fever. We want to prevent this dahil kung paulit-ulit, magkakaroon ka ng higher chance of getting rheumatic heart disease or damage to the heart. And right now, the recommendation is benzathine pen-G depending on the weight. Pwedeng 600,000 or 1.2 million units. Okay? Every 21 days. Okay? So, ideally, it's 21 days, lalo na sa Pilipinas because we're living in a we're living in a country with high endemicity, high risk for having rheumatic fever. Okay? Because in other countries na low risk for recurrence or having RHD or RF, some would say pwede na yung 28 days. Some guidelines and recommendations would say 28 days. Pero in the most recent ones here in the Philippines, pasok tayo dun sa high risk for developing RF and RHD. Our recommendation is 21 days. Okay? Oral, hindi na ganun ka-recommended dahil hindi ganun kaganda yung tolerance, yung compliance, should I say. Pen-G for 7 days, no. Definitely not. Again, we're talking about prevention. Okay? Newborn was discharged from the nursery at 2 days old, okay? Tapos, na-note ng mother na hirap siyang huminga, tachypnic, tachycardic, and strong pulse in the right brachial but very weak in both femoral arteries. And if you have this, alam na natin dapat ang sagot dyan. So, malakas yung pulse niya sa taas, sa baba, sa extremity, sa paa, mahina. dahil merong obstruction, okay? This is coarctation of the aorta. And this is one of the diseases that is being screened in your critical congenital heart disease screening. When I was a resident, this was being studied. Now, it is being practiced. So, I'm sure nakita nyo na yan, di ba? Lahat ng newborn na dinidischarge, i-check nyo yung pulse ox sa right hand at saka sa right foot. Dapat more than 95% both, and dapat yung difference ng right hand sa right foot dapat not more than 3%. Kasi pag more than 3% yung difference, then probably you have a problem, and one of which is your coarctation of the aorta. You have hypertension in the upper extremity, weak, delayed, or absent femoral pulses, and on x-ray you will see rib notching, although medyo mas late pa lumalabas yan. Okay? 3-year-old boy presented with 7 days of remittent fever, but his CBC is normal except for high platelet. 7 days na mataas yung lagnat, tapos ang taas ng platelet. Nag-iisip ka ng Kawasaki. Which of the following is inaccurate? So among these are all features except one, which is fluid-filled rashes. So again, remember in Kawasaki, the rashes should not be vesicular. Hindi pwedeng may vesicles, okay? The same is true. Conjunctivitis, pero hindi pwedeng may exudates. Hindi pwedeng purulent, okay? Again, the problem in Kawasaki is inflammation of your medium-sized arteries. So, inflammation siya, hindi siya infectious. Dapat walang mga vesicles yan, okay? So, all the rest, there are findings in Kawasaki. So, fever more than 5 days and at least 4 out of your 5 features. Mapula siya from head to toe. Mapula ang mata. Mapula ang lips. Mapula ang dila. Mapula ang katawan dahil sa rashes. Namumula rin yung extremities dahil nagkakaroon sila ng peeling ng kamay at paa. That is your desquamation. So, ang daling tandaan for me, that's my mnemonics. Kawasaki, namumula from head to toe. Plus, meron kang adenopathies. And again, it should not be suppurative. This should be non-vesicular. And your conjunctivitis should have no exudates. Those are the qualifiers. Okay? 17-year-old is 4 feet 11 inches tall while her parents are normal of height. Okay, so maliit si patient pero normal yung parents niya. Significant for lifelong short stature and cardiac surgery when she was 3 years of age. Okay, and never had menstrual period. Okay. What is the most helpful test for this girl's condition? So, ano isipin nyo? Short stature, cardiac problem, walang menses. You can think of Turner syndrome. You do your chromosomal analysis. So, Turner syndrome is 45X, and these are the features that you see. Low hairline, fascies, okay? Constriction of the aorta, coarctation yan, tapos yan. Wala silang uterus, rudimentary kanilang ovaries, no menstruation, so forth and so on. Right? Possible condition that would explain short stature with delayed growth and puberty, but the normal height is normal. Okay? So, maliit siya, pero yung final height niya normal. This is what you call your constitutional short stature. Okay? In constitutional short stature, remember that your chronologic age is greater than your bone age. Okay? So, ito yung mga differential diagnosis, pathologic short stature. So, talagang bagsak yung kanyang height. Okay? Tapos may iba siyang problem. Ano yung mga yan? Pwedeng marami. Chromosomal abnormalities, thyroid problem, dami. Familiar short stature, maliit lang talaga sila lahat. And when you look at the family, yun, maraming maliliit sa family nila. And the final height is mababa. Final height is low. As compared with constitutional short stature, yung inyong final height nagiging normal. Okay? And again, sabi natin kanina, constitutional short stature, chronologic age is greater than bone age. In familiar short stature, your bone age is consistent with your chronologic age. Laging tinatanong sa exam yan. Okay? So, normal range for height, delayed growth in one parent, but average final stature. So, mababa, pero maliit sila at one point in time, pero yung kanilang final height nagno-normalize. So, take a look at this. Okay? So, ito yan. So, familial short stature, maliit siya hanggang paglaki niya, yung final height niya maliit talaga. Pero pag constitutional short stature, ito siya. So, maliit, pero ang final height, yan, pupunta siya sa normal. Okay? So, please remember that. Chronologic age greater than bone age. In familial short stature, chronologic age is consistent with bone age. Alright? 10-year-old girl, diffusely enlarged thyroid. So you have a goiter. Okay, in children, anong unang iisipin pag may goiter? Diba? Maraming pwedeng differentials, pero ang pinaka-common actually is your Hashimoto's thyroiditis. And is this compatible? TSH is mildly elevated. T4 is normal. So almost euthyroid pa siya. Okay? Again, compatible ba yan? Yes, most of your Hashimoto's thyroiditis is compatible with a euthyroid picture. Euthyroid, so hindi siya hyper, hindi siya hypo. And they present with goiter, okay? And you want to verify if this is Hashimoto's thyroiditis, what test can you do next? Of course, you do your ultrasound, pero for verification, ang pinakamagandang sagot, because you're thinking Hashimoto's thyroiditis, okay, you do your thyroid peroxidase antibody. So your lymphocytic Hashimoto or autoimmune thyroiditis is the most common cause of thyroid disease in children. Etiology is autoimmune with lymphocytic infiltration, and because it's autoimmune, you look for the antibodies, specifically your TPO antibodies, your thyroid anti-peroxidase antibodies, 90% of the time. Most are euthyroid and asymptomatic aside from the manifestation of goiter. Which of the following scenarios depict abnormal pubertal development? So again, ito yung mga mini-memorize lang talaga natin. Among the choices, okay, ito yung sagot. 14-year-old girl, tapos stage 1 pa rin yung breast niya. Okay? 2 inches after menarche, 14-year-old, pasok pa yan. 12-year-old with 3 ml testis bilaterally, pasok pa rin yan. Tanner stage 2 sa right breast and Tanner stage 3 sa left breast, magkaiba yung Tanner staging. Yes, that can still be normal. Okay? So remember the progression. So this is according to Nelson. So girls, Telarch at 8 to 12, followed by pubarch, growth spur, and then menarche. Okay? So 9 to 16. Sa boys, ang nauuna is gonadarch, pubarch, adrenarche, nahuhuli ang growth spur. Definition of precocious puberty is 8 years old in boys, 8 years old in girls, 9 years old in boy. Ibig sabihin, pag nagkaroon ka ng secondary sexual characteristics before 8 in girls and before 9 in boys, that is considered precocious. Or kabaliktaran, pag wala ka pang secondary sexual characteristic by 13 in girls or 14 in boys, that is considered delayed puberty. Okay? 4-year-old, rounded face, lump on her back, buffalo hump, hypertension. Okay? What is the most likely diagnosis? Straightforward, this is Cushing's syndrome. Okay? So, obesity, hypertension, because of your elevated levels of cholesterol, the most common etiology is the presence of your adrenocortical tumor or pituitary adenoma. Okay? And these are the findings. Okay? 6-year-old male presents with 1-day history of dark-colored urine, hypertensive with edema. So, hematuria, hypertension. Nag-sore throat siya 2 weeks ago. Pasok yan. Anong iisipin natin? This is post-streptococcal glomerulonephritis. And what are the findings that are expected? Okay? Pag nag-renal biopsy ka, may IgA deposits? No. PSGN nga inisip mo eh. Urinalysis should be resolved for 5 to 10 days? No. Kasi usually, di ba sabi nga natin, microscopic hematuria may be present for up to around 1 year, di ba? Parang 6 months to 1 year, parang ganun. Tapos protein of 3 plus and 4 plus plus hypercholesterolemia would be found. This is more consistent with nephrotic syndrome. This patient has nephritic or glomerulonephritis kasi hematuria, hypertension, di ba? HOHA. So, PSGN, low C3, normal C4. Okay? So, remember, throat type 12, serotype 49 sa skin nanggagaling. Okay? So, these are your nephrogenic strains of your group A beta hemolytic strep, okay, or your strep pyogenes. Okay? Common in 5 to 12, it's immune complex mediated. This is type 3 hypersensitivity reaction. It presents with edema, hypertension, decreased urine output. Okay? So yan, microscopic hematuria can persist. So hindi pala 6 months. So 12 months to 24 months after the initial presentation. Okay? Which of the following statements regarding nephrolithiasis in children is correct? Okay, alin dyan? Okay, medyo complicated na tanong. Nephrolithiasis, okay? Struvite stone are the most common type of stone in pediatric patients. Actually, it's not struvite. It's calcium phosphate and calcium oxalate. Okay? Hypercalciuria is usually associated with hypercalcemia. Okay? Hypercalciuria is a common risk factor in children with renal stones. Okay? But However, most of the patients are normocalcemic. Okay? Sodium citrate should be given to prevent calcium-containing stones. It's not sodium citrate, it's potassium citrate. Okay? Kapag sodium citrate yung binigay natin, yung increase in sodium increases hypercalciuria. It might even trigger stone formation. So among the choices, the best answer is stones less than 5 millimeter in size will usually pass spontaneously. Okay? And I think this is a very specialized question again. One of those not fair. Okay? Ito yung mga question na medyo consultant or subspec level question pa yan. Pero yeah, sometimes lumalabas eh. What is the most common histologic type of nephrotic syndrome? Ito, board exam question to. Nephrotic syndrome, think of minimal change disease. Pag nag-biopsy kayo, hindi siya nag-respond sa steroids. Minimal change, nag-steroids ka, dapat gumaling. Hindi siya nag-respond. On biopsy, probably that is FSGS. Please remember that. Focal segmental glomerulosclerosis. So, next to minimal change. Pag may nephrotic ka, ang susunod na isipin mo, pag hindi nag-respond sa steroids, it's FSGS. Okay? 7-year-old boy previously diagnosed to have nephrotic syndrome. Nagbigay ng steroids, lost to follow-up. Sabi natin, matagal ang treatment ng steroids sa nephrotic. Okay? Sa ER, irritable, distended, and tender. What is the most major complication of nephrotic syndrome that could explain this? One of the most common complications of nephrotic syndrome that is not treated is your spontaneous bacterial peritonitis. Okay, so again, nephrotic syndrome, heavy proteinuria, decreased albumin, lipids high, and edema. Okay, 90% is idiopathic. Minimal change is the most common diagnosis. If not, next is your focal segmental glomerulosclerosis. Treatment is steroids. Okay? Previously healthy 5-year-old girl is brought to the ER due to bloody diarrhea, pallor, and fatigue. So, bloody diarrhea, pallor, fatigue, tachycardic, 100/70, dry mucous membrane increase, WBC, hemoglobin is low, anemia, platelet is low, thrombocytopenia, BUN and CRE is elevated, renal problem. What's your next diagnostic step? Anong sakit? So, 2-step tayo. So, I really love how these Pearls questions are constructed by Dr. Apunumbayan. So, it's 2-step. Bago mo masagot, kailangan alam mo muna yung diagnosis, which happens a lot in the board exam of pedia. So, meron kang bloody diarrhea, may history ka ng bloody diarrhea. Tapos, meron kang anemia, thrombocytopenia, and renal failure. RAT. Anong sakit yan? Hemolytic, uremic, syndrome. And what do you look for? You want to see if your anemia is microangiopathic. Diba? Microangiopathic hemolytic anemia. And how do you see that? You use your peripheral blood smear. Diba? So, obtain a PVS to look for the type of anemia. LDH, mga markers, and reticulocyte count also have full. Pero ako, ang clincher ko dito is yung peripheral blood smear. Microangiopathic, hemolytic anemia, thrombocytopenia, and renal insufficiency. Maraming pwede mag-trigger, but ang pinaka-common na nag-trigger is your Shiga toxin. Okay? Sorry, not Shiga toxin. No. The most common trigger is your EHEC, enterohemorrhagic E. coli, but it can also be triggered by your Shigella. Okay? You diagnose a 1-year-old well-appearing febrile male with UTI. What is the best management option for this patient? Okay? Lahat ba na may pyelonephritis ay ina-admit for parenteral therapy? No. Okay? Hindi lahat yan. Okay? A tip for you guys is in the exam, pag nakikita nyo yung all, most probably hindi yun yung sagot. Okay? I'm not saying all the time. Pero pag sinabi dyan, all infants with ganito, dapat ganyan. So, basahin mabuti, malamang hindi yun yan. Okay? Give 1 dose of ceftriaxone and send home on oral antibiotics. We don't usually do this. Okay? X-ray of the kidneys, ureter, and bladder? No. Ultrasound. Pwede pa, lalo na kung first UTI yan. The best answer would be this. So, send home on 10 days of oral antibiotics after doing, of course, your urine culture. You have to do your urine culture. You're thinking of UTI, pyelonephritis, ideally do your urine culture para kung ano yung growth niyan, kung may growth man, makakapag-shift ka ng inyong antibiotics sa proper antibiotics, and you have to do close follow-up. Okay? You don't have to admit this patient. Well-appearing, okay, may lagnat lang siya, pero well-appearing siya, walang ibang problems, then you can treat orally. Okay? 10-year-old girl presents with sneezing, congestion, itchy, and watery eyes. Symptoms of atopy. Okay. Wants to know if the symptoms are due to allergic rhinitis or viral infection. What's the most common finding on PE of allergic rhinitis? Clerk internship. Dapat alam natin yung sagot dyan. Okay. It's your pale, boggy pale and large turbinates with rhinorrhea. Okay, and it's pretty easy to differentiate viral URTI versus allergic rhinitis. Allergic rhinitis establish the chronicity, establish the family history, and usually walang fever yan. Viral infection, on the other hand, it's more on acute manifestation and can have fever and other symptoms of viral upper respiratory tract infection. Okay? So yan, sneezing, rhinorrhea, obstruction, sabi na natin yan, allergic salute, rabbit nose. Management, if of course, antihistamine, oral antihistamine, and your inhaled steroids. Intranasal corticosteroids. Kumakain sila ng seafood buffet. Sarap. Tapos, acute onset, wheezing, hives, and tongue swelling. Allergic reaction. Okay? Anaphylaxis, if 2 or more organ system or nagsashock siya, di ba? Dinala sa ER, a delay in administration of this drug will be related strongly to increase mortality and morbidity. Okay? If this were anaphylaxis, technically speaking, anaphylaxis na ba to? Yeah, wheezing, hives, tongue swelling, dalawang organ system na yan. Meron ka ng lungs, meron ka ng skin. Then yes, this is anaphylaxis. Of course, you give your epinephrine. It's life-saving. Okay, epinephrine, life-saving yan. Okay. 73, 6-month-old male with SCID, severe combined immunodeficiency syndrome. 1 month post-hematopoietic stem cell transplant. So, nakapag-transplant siya. This time, nagkaroon siya ng rashes, okay? Tapos, nagkaroon siya ng difficulty of feeding because of diarrhea and meron siyang ictericia, okay? Elevated liver enzymes and bilirubin. What is the pathogenesis of this condition, okay? So, this is your graft versus host disease. So, post-stem cell transplant. Anong nangyayari sa graft versus host disease? Okay? Ang nangyayari dito is your donor lymphocytes are activating against your patient's own antigen. Okay? So, please remember that. In GVHD, graft versus host disease, your donor lymphocytes is activating or acting against the patient's antigen. Okay? Letter B is not the answer because GVHD is not infection. Okay? It's not infectious. The drugs cyclosporin, tacrolimus, methotrexate, these are given to decrease the immune system response rather than causing the symptoms. Okay? And for letter D, sabi host lymphocytes rejecting the donor cells. It's actually not. It's your donor T cells, okay, that is causing the problem and the release of your inflammatory markers. So again, the donor T cells from the transplant attacks your recipient's antigen on the target tissue. The donor T cells activate the CD4 and CD8 cells and produces cytokine that causes tissue damage. So please remember that. This is usually seen in patients post-stem cell transplant. It develops 2 to 6 weeks and it involves your endothelial cells, skin, liver, and intestine. Treatment is to give your steroids, monoclonal antibody targeting, extracorporeal photophoresis, so forth and so on. Okay? 13-year-old boy presents with recurrent abscess, recurrent pneumonia with pneumaticil, and eczema. What is the primary immunodeficiency of this patient? Okay? Di George, madali lang si Di George i-rule out. This is your catch-22. Okay? Hyper IgE, Bruton, and selective IDA. Yes, all of this may present with recurrent abscesses, recurrent pneumonia. Okay? The thing is here, pinapakita niya sa inyo na abscesses, pneumonia with pneumatocyl. You think of staphylococcus. And among these choices, it's your hyper IgE syndrome that presents notoriously with recurrent staphylococcal infection. Okay? But guys, in reality, these syndromes right here in front of you, for the diagnosis, it's actually determining the levels and doing your panels, okay, blood test panels. Mahirap siyang i-differentiate just by history and PE alone. But suffice it to know, ito yung mga features nila. Hyper IgE is IgE more than 2,000 IU, recurrent staphylococcal pneumonia and abscesses. So staph is notorious in having pneumatocyl and air leaks. Okay? Bruton's X-linked agamaglobulinemia. Usually presents with ear infection, bronchitis, or pneumococcal pneumonia. The George is easy. It's catch 22. Catch is cardiac, usually TOF, abnormal fascies, thymic aplasia, cleft palate, hypocalcemia, and chromosome 22q11.2 deletion. Okay? Selective IgA deficiency is IgA less than 10. They present with recurrent infections in the respiratory, GI, and urogenital tract. 75. Patients with disorder of B-cell development susceptible to infection from encapsulated organisms such as your pneumococcal, infections, and their viral infections as well. They become symptomatic at what age? The answer here is between first 6 to 12 months of life. Again, for the first 6 months, usually your maternal immunoglobulins are still there in the immune system in the body of the baby. After which, nawawala na sila dun, lumalabas yung mga symptoms nila. 6-month-old girl presented with bright red papules and plaques. Okay, inguinal folds are involved. Okay, and actually hindi na mention sa question, pero as you can see in the image, there are satellite lesions. So this is candidiasis. The drug of choice is clotrimazole. Piperacin cream, we give that for bacterial infection. Zinc oxide paste, binibigyan pag mga diaper dermatitis. It's more of a protectant than a treatment. Pero if you have candidiasis, then you give your clotrimazole, your antifungal cream. Okay? Terbinafine is for dermatophytes. If you want to treat your tinea infections, your tinea infections. Okay? A teenager who gets stung by a bee develops urticaria within 30 minutes of the sting. Which of the following is the reaction most likely mediated by? So this is a hypersensitivity reaction type 1. It's mediated by your IgE. So please remember that. So immediate type 1 hypersensitivity. Type 2 is cytotoxic. Type 3 is your immune complex mediated reaction such as your post-streptococcal glomerulonephritis and rheumatic fever. And type 4 is your delayed type hypersensitivity reaction, example of which is your graft versus host disease. Okay? 78. Which of the following is used as a basis for tissue compatibility in recipient donor screening? And again, ito yung mga kailangan lang alam mo talaga. Mga hard facts to. At memorize this. It's your HLA, your human leukocyte antigens. Okay? Your adhesion molecules are used to monitor graft rejection. Okay? Cytokines are immunomodulators. Natural killer cells, they're more for tumors and viruses. And your HLA is the one used for tissue compatibility in recipient donor screening. You have a female with developmental delay, okay? And on and off fever with perirectal and labial cellulitis. On history, there is delayed detachment of umbilical stump. And on CBC, you have leukocytosis and neutropenia. Mababa yung WBC niya. Most likely, what is the diagnosis? So, pag pinagsama-sama lahat to, developmental delay, okay? Recurrent infection, delayed umbilical stump detachment, yes, and neutropenia, the answer for this is your leukocyte adhesion defect. Okay? Alright, and let's go through the other choices. Wiskott-Aldrich syndrome, your WAS, okay? It presents with thrombocytopenia, immunodeficiency, and eczema. So please remember that, okay? So these patients usually present with prolonged bleeding from circumcision site or bloody diarrhea during infancy. Yun nga. So it's immunodeficiency plus thrombocytopenia and eczema. Yun yung tatlong tatandaan nyo dyan. Shidiak-Higashi syndrome, keyword here is your neutrophil chemotaxis. Yan yung problema niya. Neutrophil chemotaxis. Okay, chemotaxis. So, it presents with neutropenia, pyogenic infections, albinism, and peripheral neuropathy. And of course, leukocyte adhesion defect. Actually guys, pag binigay sa exam na meron kang delayed separation of the umbilical cord, tapos immunodeficiency, then most probably wala kang ibang iisipin, kundi yung leukocyte adhesion defect, your LAD, LAD. Alright? 13-year-old male, intermittent swollen and painful joints for the past 6 months. So, on and off, okay? So, wala siyang regular check-up. You assess the vision and the eye structure and was concerned about the onset of this complication. Chronic uveitis is associated with what type of rheumatoid arthritis? So, this is a case of rheumatoid arthritis. So, you have on and off recurrent arthritis, at least 6 months in duration. Okay, so at least 6 months dapat yan. So, pasok na siya. And you have several types, systemic onset, oligoarticular, or polyarticular. Okay, And ang tanong, saan associated yung chronic uveitis? The answer is your pauci-articular, or right now it's also called your oligoarticular arthritis. So again, remember, less than 5 joints is pauci or oligoarticular. 5 or more is polyarticular, articular, and more than, okay, and if you have associated fever and other systemic manifestation, then that is systemic onset arthritis. Okay? So, yan. Systemic onset, and then yung peak age of onset niya. Mas common ang oligo compared to poly. Okay? So, systemic arthritis, you have your polyarticular, daily fever, evanescent rash, so forth and so on. Alright. A father of a 10-year-old boy asked you about his son's skin changes noted for the past 6 months. So, 10 years old na siya, may mga skin changes siya. Okay? Redness over the eyelids, alligator skin, and hypertrophic skin over the hands, metacarpal and interpharyngeal joints. And you have muscle weakness. So, you have dermatologic changes and muscle weakness. What is your diagnosis? Dermatologic and muscle weakness. Okay, dermatomyositis. Okay, so that is your dermatomyositis. Other choices: ankylosing spondylitis, think of your spine, your back pain, and yeah, it affects your axial skeleton and limbs, and it's more common in adolescent males. Okay, scleroderma, ito yung kumakapal yung balat niya. So you have your morphea, pwedeng localized, pwedeng systemic siya. Okay? Dermatomyositis is proximal and symmetric muscle weakness. Okay? And you have your dermatologic findings, your heliotrope rash, your Gutron papules. Okay? So ito yan. This is your heliotrope rash. So namumula yung mata. And your Gutron papule. Okay? This one is morphea. Okay? Morphea, you see it in scleroderma. Right? 15-year-old girl presents to the clinic with unexplained fever, weight loss, swelling of her knee. On PE, mapayat siya. Meron siyang swelling and pain sa wrist, knee, and ankles. So, medyo maraming joints na involved. Tapos, increased ESR, anemia, ANA positive, dsDNA positive, and you have proteinuria and hematuria. Okay? So, what case is this? The question, however, is which of the following is true regarding her condition? Anong case muna to bago natin masagot? So, it's a giveaway. Mukha naman siyang case ng 15-year-old, daming signs and symptoms, babae, ANA and dsDNA positive. So, SLE to, systemic lupus erythematosus. Okay? The hemolytic complement is normal. Usually in SLE, di ba, ang complement natin is decrease. Okay? dsDNA screening, no. Your screening tool would be your ANA. Okay? ANA reflects the degree of activity. Disease activity in SLE. No, it does not. Okay? Anti-Smith is found only in SLE. So actually, that is the statement that is correct. Okay? So please do remember your ANA criteria. Dati, ang ginagamit natin yung Soap Brain MD. Ngayon, unfortunately, binago na ng EULAR at saka ng ACR yung kanilang classification. Okay? Kailangan mo na ng ANA. So, ANA is an entry criterion. Okay? Dapat meron kang ANA titer or positive test because madalang na madalang ang pasyente na may lupus na negative ang ANA. It's not 100%, okay? Pwede ka magka-lupus na negative ang ANA pero sobrang baba. Parang less than 5% yata. Okay? You should have at least one clinical criteria, okay? And your additive criteria do not count a criterion if there is more likely explanation other than SLE. So, for example, may anemia siya pero may ibang cause. Kung dinugo naman siya, sinaksak siya, ganun. Mga ganun bagay. Okay? Occurrence of a criterion in equal or one occasion is sufficient. Okay? They do not need to occur simultaneously. So, pwedeng in the past. Within each domain, only the highest weighted criterion is counted. Okay? So, ito yung inyong criteria. So, medyo maliit, no? So, hopefully, ma-zoom in natin yan. So, kailangan may ANA ka. If absent, sabi dyan, do not classify as ANA. And dapat meron kang isang clinical. Okay? So, again, within each criteria, yung pinakamataas lang. So, for example, may fever yung patient mo, 2. For example, 2 yan. And then, nagkaroon siya ng thrombocytopenia. So, 6 na yan. Tapos, meron siyang seizure. So, 11 na yan. Tapos, meron siyang oral ulcers. 13. Tapos, wala siyang serosal. Tapos, may joint pain siya. So, 13 plus 6. So, taas na yan. Ilan na yan? 19. Okay? And then, you do your labs. Okay? So, sabi dito, okay, paano mo siya maka-classify? Okay? Classify as systemic lupus erythematosus with a score of 10 or more. Or if entry criterion is fulfilled. Alright? So, please remember that. So, for the sake and purposes of the board exam, you still have to review SOAP Brain MD. Because actually, nandiyan pa rin naman yung mga yan. Naka-classify lang sila, saka naka-score lang sila. Pero that's your SOAP Brain MD. Serositis, oral ulcers, usually painless. Arthritis, 2 or more joints. Photosensitivity. Blood changes, renal disorder, ANA, immunologic changes, neurologic signs, malar rash, and discoid rash. Okay? So for screening, again, I said this already, ANA. Anti-dsDNA can be used for disease activity, and anti-SMIT is only found in SLE. Okay? Straightforward question, what is the usual age of tooth eruption in children? It is 6 months. Okay? And after that, usually, may tumutubong isang ngipin bawat month onwards. Okay? And again, central mandibular incisor. You're assessing a 9-year-old girl with pyuria, okay, joint pains, and reddish pinpoint lesions in the lower extremities. You're entertaining vasculitis. What is the hallmark of henoxun line purpura? So, wala. Sinabi na niya yung diagnosis. Lucky for us. So, tinatanong lang kung ano yung hallmark. So, the hallmark of henoxun line is palpable petechiae or purpura on the dependent body parts. Okay? Plus or minus yung may abdominal pains, saka joint pains. Okay? So, these are just other findings, pero hindi siya hallmark. Ang hallmark is still your palpable petechiae or purpura on the dependent areas of the body. So, example is like this. Nakakatakot siya, no? Again, pwedeng meningococcemia yan, but look at the course, meningococcemia, the patient is very toxic. Okay? Deteriorating. Ito, usually hindi. Usually okay sila. So, it's IgA-mediated vasculitis of the small vessels, common in 3 to 10 years old, more common in male than females. Again, you can have arthritis, abdominal pain, and renal involvement in 25 to 50%. Management is supportive. Do we give steroids? Not all the time, only if there are complications. So, for example, may renal complications, severe abdominal pain. Pero other than that, the management is simply supportive. Okay? Which of the following is an uncommon manifestation of hemophilia? So again, hemophilia, factor 8 or factor 9, yun yung mga pinaka-common. Isolated PTT derangement, okay? Does it involve your platelet? Not so much. If you have factor involvement and platelet signs and symptoms, then probably you would be thinking of von Willebrand disease. Pero pag factor involvement lang, wala kang petechial involvement, then probably that is hemophilia. And ano bang manifestation ng petechiae? Wala kang petechial involvement. Wala kang platelet involvement. Okay? And ano ba manifestation ng platelet involvement? When you have platelet involvement, think of mucosal bleeding. Okay? So, sabi ko sa inyo, kapag may platelet involvement, mucosal bleeding. In hemophilia, wala kang platelet involvement, so hindi common ang gum bleeding. Okay? Hematomas, deeper-seated bleeding, hemarthrosis, GI bleeding, CNS bleeding, yes, pwede, but gum bleeding, not that common. Pwede pa rin, pero hindi common. Okay? So again, X-linked recessive siya, factor 8 or factor 9, ang pinaka-common, marami pang ibang type dyan. You have deep and delayed bleeding, joints, muscles, GIT, CNS. Okay? Mucosal bleeding is uncommon because mucosal bleeding is a function of platelet dysfunction. Sinabi na natin yan kanina. Which of the following does not present with hypochromic microcytic anemia? Okay? Chronic renal failure. Actually, pwede lahat yan. Pwede lahat yan. Okay? Pero the best answer here would be your chronic disease because initially it's normocytic, but in the long run, please do remember, in the long run, it will be microcytic as well. Okay, the mnemonics here is CLITS, C-L-I-T-S, di ba? Chronic disease, lead, iron deficiency, thalassemia, and sideroblastic anemia. Okay, tails, pwede rin, pero wala yung chronic disease dyan because, yeah, the book classifies it as normocytic. Okay, Doc, paano sa exam? Saan namin ika-classify yung chronic disease? What I would say to all the top-notch students for PEDYA, if you were asked of anemia of chronic disease, I think it's more proper to classify it as microcytic with your tails. So, CLITS, mnemonics. Okay? Pare-parehas tayo ng sagot para pagdating sa MPL, ganda laban natin. Okay? Alright. Healthy 2-year-old girl presents with acute onset of petechiae, purpura, and epistaxis. Hemoglobin is okay. WBC is okay. Differential type count is okay. Platelet is significantly reduced at 20,000. So, dapat yan, nasa 150 pataas yan. And a few weeks ago, you have an upper respiratory tract infection. Okay? Which of the following is most likely diagnosis? So, that's very important. Viruses trigger a lot of problems in children. Can trigger Kawasaki, reactive arthritis, and dami. So, very important yung history na may previous infection siya. This one is a giveaway. So you have thrombocytopenia, all the rest are normal. And on a child na nagko-konting bleeding siya pero relatively active and well siya, this is ITP. This is idiopathic thrombocytopenic purpura. ALL in a plastic, automatic out na yan because that will present with pancytopenia. 2 or more cell lines dapat yung involved. Sa kanya, isang cell line lang, platelet. DIC, very toxic looking yung batang yan. So, hindi yan DIC. So, ITP. Okay? So, yeah, that's it. So, it's an autoimmune platelet dysfunction. Most common is triggered by viruses, pero may mga ibang reasons din. Okay? On BMA, if you do decide to do BMA, you have increased megakaryocytes with other marrow elements that are normal. Okay? 70% will resolve without treatment in 4 to 6 weeks. So, yun yung timeline niya. So, acute ITP is 6 weeks. Pag beyond that, then you do your workup. Okay? Management, anong gamot? Pwede mag-steroids, pwede mag-IVIG, pero for most cases, kung di naman sobrang baba, yung iba ino-observe lang nila. Okay, so that is your ITP. And again, platelet problem, expect mucosal bleeding. Petechiae, no, petechiae, nose, gum bleeding. Yan yung mga mucosal bleeding niya. Okay? Recurrent gum bleeding, menorrhagia were noted in a 15-year-old female. CBC and platelet count was normal. PT was normal, but the PTT was prolonged. What is your most likely diagnosis? So, gum bleeding, menorrhagia. You think that there's platelet involvement dahil may mucosal bleeding ka, may gum bleeding ka. However, yung PTT mo deranged din. So, sabi natin, PTT derangement, hemophilia, kaya lang ito mukhang may platelet involvement. Anong sakit yun? Sinabi ko na kanina, di ba? Think of your von Willebrand disease. Okay? So, alright. It's the most common inherited bleeding disorder. Your problem is your VWF, okay? Your VWF, your von Willebrand factor, is a carrier for factor 8, kaya tinatamaan din yung PTT nyo. And it's a cofactor for platelet adhesion. Huwag pagpapalitin, von Willebrand, the main problem is platelet adhesion. Glanzmann thrombasthenia, the main problem is platelet aggregation, okay? So, nagkakaroon ka ng problema sa platelet adhesion, that's why you have mucosal bleeding. At the same time, meron ka ring factor 8 problem, so you can have deep-seated bleeding as well. Okay, usually there's a family history, and yeah, decreased VWF level, decreased factor 8, prolonged bleeding time, and increased PTT. Remember that bleeding time is a function of your platelets. So, pag may problema ka sa platelet, yung bleeding time mo nade-derange. Okay? So, again, platelet count is normal. Your platelet function ang may problema sa von Willebrand disease kasi ang problema mo is not the number of platelet but the ability to adhese. So, yung adhesion. Okay? 89. A patient newly diagnosed with ALL, WBC 70,000, nag-induction chemotherapy, taas ng WBC niya, no? Which electrolyte abnormality can you see with tumor lysis syndrome? Okay? So, among the choices there, if you think about it, if you don't memorize it yet, of course, ideally, you can memorize it, pero kunwari, gaya ako, hindi ko na-memorize lahat. If I will do my testmanship skill on this one, tumor lysis syndrome, you have cells lysing, pumuputok. Pag pumutok yung cells, the intracellular component, lumalabas yung mga yan. So, you would expect na dapat mataas yung potassium. So, out na yung dalawang hypokalemia, you're left with this two. So, hyper K, okay. Phosphate, tataas ba? Yes, tataas yan. Uric acid, tataas din yan. Sodium, it's extracellular, so malamang hindi yan, normal yan. So again, di ba? Using my basic science knowledge to answer questions, that's what I'm trying to teach the students, okay? So the answer is this one, hyper K, hyperphos, hyperuricemia, normal sodium. Actually, hindi prerequisite ang normal sodium. When you look at tumor lysis syndrome, it's actually these three, hyper K, hyperphos, and hyperuricemia, okay? So rapid breakdown of tumor cells, usually more commonly seen in solid tumors. So ito sa example, ALL, pwede pa rin naman, lalo na pag sobrang taas yung mga WBC, pero mas common yan sa mga may bukol, okay? You can have renal failure because of your hyperuricemia. Electrolytes elevated, those that are intracellular, okay? So treatment, hydration, xanthine oxidase inhibitor here, allopurinol, okay? 7-year-old boy present with sudden onset shortness of breathing and pallor. Binibigyan siya ng trimethoprim, sulfamethoxazole for UTI. Hindi natanong nung pediatrician yung kanyang history. Na hindi tinanong dapat, meron ka bang ganitong sakit? Pero hindi, nabigay niya. Okay? And then you have organomegaly because of hemolysis and ictericia because of hemolysis, jaundice. Okay? Most likely diagnosis, ano bang tinitrigger ng cotrimoxazole? Yung tinitrigger ng mga nitrofurantoin, ng mga anti-malarial nyo? This is your G6PD deficiency. Okay? So, remember the drugs to be avoided. Fava beans, yung mga pagkain, soya, ding-dong, mixed nuts, okay? Left-sided abdominal mass, IVP, so sa kidney siya, from the left kidney, okay? On X-ray, you have metastasis na, multiple pulmonary nodules. Most likely, this is. So, abdominal mass, ang mga pagpipilian mo lang naman, Wilms, hepato, sa neuroblastoma, okay? Neuroblastoma arises anywhere. Magulo yan kung saan-saan. Pwede rin actually siya sa kidney. Hepato, alam mo, galing sa liver. So, automatically, out na si hepatoblastoma. Wilms sa neuroblastoma ka na lang dyan. So, pag galing sa kidney, okay, then probably this is Wilms. Okay? Better answer would be Wilms. Although, technically, pwede rin neuroblastoma. Pero Wilms, okay? So, 2 to 5, painless abdominal mass that does not cross the midline kasi nga, kidneys lang siya. As compared to neuroblastoma, it crosses the midline. Notoriously, pulmonary ang kanyang metastasis. So please do remember that, the difference between Wilms and neuroblastoma. I think in one of my lectures, I made a table on that. Okay, rhabdomyosarcoma, usually head and neck yan. So one example of your rhabdomyosarcoma is your sarcoma botryoides. 8-year-old, fever, bruises all over the entire body, pain in both legs, okay, ecchymosis in the trunk and extremities, organomegaly, anemia, elevated WBC, thrombocytopenia, 2 or more of your cell lines are affected, you're thinking of a leukemia or probably an aplastic anemia. What next test should you do? Of course, you do your bone marrow aspiration. So again, the most common malignancy in children is leukemia, and among your leukemias, the most common is your ALL. You have to know ALL by heart. Okay? Abdominal tumors in children where HCG is included or increased, malamang ang tanong dyan, is your teratoma. A 15-year-old boy complains of worsening right thigh pain, awakening from sleep. That's always a red flag. Nagigising siya sa tulog niya dahil sa sakit. Okay? On X-ray, sunburst pattern, and that is your osteosarcoma. Because if it's Ewing sarcoma, you're looking for the onion skinning. So remember, almost same ang incidence. Okay? Difference, osteosarcoma, usually metaphysis siya. Ewing's, diaphysis. On X-ray, sunburst. On X-ray ng Ewing's, onion skinning or moth-eaten appearance. So, yan. So, this is your sunburst. This is your onion skinning. Alright? Episodic severe headache for the past 6 months. Okay, once every 2 weeks, lasts for about 2 hours. His mother notes that he pulls the cover over his head and pinapapatay niya yung ilaw. So, natitrigger siya ng mga sensitivity sa ilaw, sa noise, ganyan. Okay? And yung nanay niya may history. Okay? So, the mother also experiences severe headaches every month. Okay? With nausea and vomiting. The neurologic exam is normal. Your diagnosis, this is compatible with migraine. Okay? So, for headaches in children, you have to classify if it is primary or secondary. Kasi kung secondary siya, you treat the underlying cause. Kunwari, meron kang increased ICP, meron kang bukol, i-treat mo yan. If it's primary headache, katulad ng migraine, you treat the headache itself. Okay? So, differentiation is critical because depending kung primary or secondary yan, your management and your diagnostics will differ. Okay? Primary headache, usually it's chronic. Okay, recurrent, usually frontal or temporal. The description is throbbing or squeezing any time of the day. Okay, usually there's nausea, okay, more than vomiting, and sometimes in migraine you can have aura and photophobia as well. Secondary headache, this is what you should be more watchful for. Babantayan nyo siya. Acute, so first episode of severe headache, red flag yan. Okay, progressive, lumalala ng lumalala. Okay, more of pressure yung nararamdaman pag gising sa umaga. Ang migraine, pag pinahinga mo, kinabukasan, nawawala na siya. Most of the time. May mga severe migraines na hindi nawawala ang sleep, pero it's usually relieved. Pero ito, worst at waking up, delikado yun. Okay? Vomiting. Okay? Sa migraine, may nausea and vomiting. Pero sabi dito, yun na, more of nausea. Pero ito, suka ng suka siya. Halos wala siyang nausea, pero suka ng suka. Tapos nagduduling, may neurologic findings ka. Then, you have to work this up. Okay? So, this mnemonics is useful. Okay? So, kailan ka mag-work up? When do you do your workup if you have a patient with headache? So, Snoopy. May systemic signs ka. Abnormal neurologic signs. Severe acute onset. Occipital area. Precipitated by Valsalva. Progressive. Walang history. And less than 6 years old. Okay? So, yan. So, temporal pattern of the different headache types. Okay? Migraine versus tension type headache. So migraine, nasa handout nyo yan, Fruant. Sabi, family history, relieved by sleep. Usually unilateral, usually moderate to severe. With aura, abdominal pain, nausea and vomiting, and throbbing. Okay? Tension naman, usually after puberty, tension, pag na-stress sila. Okay? Waxes and wanes, band-like tightness, frontal region, walang nausea and vomiting. It is diagnosis of exclusion. So please remember that, the difference between migraine and tension type headache. Unrestrained child is ejected through the windshield after a motor vehicle accident. So, again, place your seatbelts. Okay? Very important for children. Altered mental status, nag-seizure siya, increased ICP. Of course, the answer here is to do your CT scan. Okay? So, for traumatic brain injury, there are a lot of guidelines. Okay? The one that we use is PICARN because it has been proven to have a higher sensitivity and specificity. Okay? And these are the guidelines for less than 2 years old for indications for workup or imaging. Pag less than 2, walang scalp hematoma, okay, walang fracture, and normally then probably you don't have to work up the patient. More than 2, pag walang vomiting, walang fracture, walang severe headache, pwede mo siyang hindi imaging. Okay? So, yeah, be familiar. PICARN, yun yung tinatanong nila sa exam. Okay? Febrile 1-year-old male brought to the ER, high-grade fever for the past 2 days. Habang ini-interview mo, nag-seizure siya. First time niyang nagkaroon ng seizure at this point, what do you do? EEG ba? Lumbar tap ba? Pasok ba siya? 1-year-old, lumbar tap? Yes, pasok yan. Okay? Give oxygen, IV line, observe, oxygen, diazepam, admit. Anong sagot? Maraming nalilito dito. Ang sagot nila is lumbar tap, doc, kasi pasok siya dun sa PPS criteria. Pag 18 months pababa, first febrile seizure, dapat naka-lumbar tap. Yes, tama yun. But again, before you do your lumbar tap, your diagnostic, you manage your patient airway, breathing, circulation. Okay? Nagsi-seizure pa yung pasyente mo eh. So, you give your oxygen, diazepam, admit. Okay? Kung hindi na siya nagsi-seizure, kung sinabi dito, tumigil na yung seizure, I would probably answer letter C. Kung hindi na siya nagsi-seizure. Pero here, the best answer is letter D. 2-year-olds brought in for evaluation. Okay? Nauntog siya habang umiiyak. Okay? Tapos umiyak siya. Sobrang iyak niya, nangitim, namula yung mukha niya, tapos tumirik yung mata niya at nawala. Nakakatawa eh. Actually, nakakatakot yan. Pero if you've seen patients like this, and you know that this is a benign condition, nakakatawa siya yung bata. Wah! Sobrang namumula na siya. I've seen once. Most of the time hanggang dun lang sa pamumula. Nasa anong ginagawa ng mga lolo pag namumula yung mukha ng mga bata, di ba? Kukunin nila yung baby, tapos ipalin nila yung buka nga. Sobrang funny ng pamahiin na yan. Anyways, I've seen one patient in the OPD na talagang nawalan siya ng malay, tumirik yung mata niya, tapos nawalan siya ng malay. Of course, pag ganun na nawalan ng malay, wino-work up natin kasi pwedeng seizure eh. Pero if the patient recovers, tapos seems tired, wala siyang ibang problem, then, and normal yung mga workup and PE nyo, the answer for this is your breath holding spells. That's a typical textbook description of your breath holding spells. Iiyak siya, titigil, mumula, hindi siya humihinga habang umiiyak siya, tapos yan, pwede siyang mawalan ng malay. It's definitely not temper tantrums, it's not tonic-clonic seizure, it's not also myoclonic seizure. Kwento pa lang, umiiyak, tapos dun siya namula, hindi humihinga, then that is breath holding spell. Okay? Episodic staring. So, ito naman, nag-i-stare siya, titigil siya, tapos nakatulala lang siya. Parang yung mga students ko sa board exam, pag nag-review sila ng PEDYA, parang minsan nakatulala na sila, no? Hindi na nila ma-process yung sinasabi ko. Okay? So, it occurs anytime and interrupts the activity. Minsan may fluttering siya ng eyelids. Stop speaking during the attack. Mabilis lang, 10 to 15 seconds. Normal development and behavioral. Walang ibang problema. Neuroexam is normal. This is typical of your absence seizure. Okay? So remember, absence versus myoclonic, medyo magkalayo naman yan. So absence is sudden cessation of motor activity, speech with blank facial expression and flickering of eyelids. Uncommon before 5. Walang aura. Walang post-ictal state. Pagkatapos, okay na siya. Rarely more than 30 seconds. And hindi nawala ng body tone. Myoclonic jerks sila, brief symmetric muscular contraction with loss of body tone. Okay? Sa babies, spasm yan. So, ito yung sa trunk naman. Para siyang nagsisit-ups. Okay? And our last question for this review. Okay? Condition is characterized by deficit in socialization or communication with restricted repetitive patterns of behavior. And I've said this already, this is your ASD, Autism Spectrum Disorder. Alright, we've learned a lot in the past 3 or so hours. I hope that you get high scores in PEDYA, guys. I hope marami kayo natutunan sa aming dalawa ni Dr. Punong Bayan. Good luck on your exam, and I will see you, future colleagues, okay? But this is not the last. We will meet again before your PEDYA exam. I think I still have several lectures left to go. Thank you very much for listening, and this is Doc Ian once again. All right?